5 minutes. Thank you for joining in large numbers. Thank you. Thank you.
I request everyone to please rename themselves.
Very bright good morning and a warm welcome to all the dignitaries and delegates to the 21st annual conference of IMA Dombivli, IMAFEST 2020. For any branch of for my branch of IMA Dombivli, IMAFEST is nothing short of a festival. If we all members of IMA Dombivli celebrate together and as per our tradition, where dear guests visit our homes. Even in IMA Fest, we welcome all the delegates from all over Maharashtra and India. Friends, friends, the numerologically lyrical year 2020 is a golden jubilee year of IMA Dombivli, and we had planned grand celebrations to make it memorable. But as we all know, the global COVID pandemic has halted all the celebrations across the world. But But such things have never deterred us, and here we are having a great virtual celebration of our IMAFES. And our conference has already kickstarted since yesterday night with our cultural conference Navran. Today and tomorrow, we have planned an excellent academic feast for our brain cells, and we have lined up excellent scientific sessions from various branches and from the world-renowned speakers of great repute. I will give a very brief outline of the various sessions over coming 2 days. We have four lectures in Saturday pre-lunch session, four lectures in Saturday post-lunch session. On Sunday, we have four lectures in pre-lunch session. We have a grand Dr. U. Prabhakar Rao origin ceremony with orator none other than Padma Shri Honorary Dr. Raman Gangadkar sir on Sunday at 12:30 p.m. Sunday post lunch there will be three scientific sessions and then there will be valedictory function followed by Navrang again at 7 p.m. And before we proceed further, few very important instructions for the delegates. Make sure your full name is visible on the screen from where you are logged in. When you are logged in using the link which was provided, there might your screen might show word common which was used, but then you will have to rename yourself. So that option is available in your device. Please use it. Uh, for you need to log in throughout the session for 4 MMC credit points because the images will be clicked at regular intervals. This is need of and requirement for MMC credit points. Any question and answers can be asked in the question answer option which is available, and we will take up the questions if the time permits. So now we begin our inauguration function. Uh, uh, Again, a warm welcome to everyone. And as our Indian tradition goes, we begin any celebration with blessings of God. And Lord Ganesha is a Lord of wisdom. And let's begin with Ishestavan. And we will have a video of it. Aditya, can we have the video of Ishestavan? With blessing of God, all the darkness gets dispelled. And as again our tradition says, we will have a lamp lighting at the hands of organizing committee. Dr. Mangesh Pate, Chairman, IMAFEST 2020, Dr. Sunit Upasni, President, IMA Dombivli, Dr. Hemant Patil, Honorary Secretary, IMA Dombivli, Dr. VK Chinchole, Honorary Treasurer, IMA Dombivli, Dr. Bhakti Lot, Dr. Makran Kanpule, Organizing Co-Chairperson, IMAFEST, Dr. Bhakti Lote, Organizing Secretary and President-elect, IMA Dombivli. So we will have lamp lighting video. Aditya, can we have that?
मोबाईलवरून केल्यात तसं
Any program of IMA Dombivli is never complete without the women power of IMA Dombivli, and here we all are organizing team. Thank you, Aditya. Now that we have received the blessings of Goddess Rajya Rajeshwari, the Goddess of Lamp, we begin with our dignitaries' address. And I request Dr. Hemant Patil, Honorary Secretary, IMA Dombivli, to introduce and welcome Dr. Sunit Upasni for his presidential address.
Thank you, madam. It was a very warm inauguration with the blessings of Sri Ganesha and lamp lightning. It is very auspicious in our culture. So we have stick to our roots. We started with our cultural protocols. I request Mr. Aditya to please share the slide of Dr. Sunit Upasni, sir. Yeah. Dr. Sunit Upasni doesn't need any introduction. He is a senior pediatrician from IMA Dombivli. He's a senior IMA member. He has worked on many posts in IMA for so many years. He is a very humble and great human being, and currently he is hosting the position of President IMA Dombivli. So I request Dr. Sunit Upasni sir to please address the forum as a presidential address. Over to you, sir.
Thank you, Hemant, for the kind words. Good morning, all. I, Dr. Sunit Upasni, IMA Dombivli President, welcome all the dignitaries and delegates for our 21st annual conference, IMAFEST 2020. This is our Golden Jubilee year, and I feel proud that I am the 50th president of this prestigious IMA Dombivli. Celebrating 50th year is a milestone for the branch. Looking back at all the past presidents, way back from 1971-72, Dr. Varde was our first president, and we have grown to great heights from then. This is because of the firm foundation which was laid by the past presidents. They have guided us there in each and every moment of ours, and slowly and steadily we have rose to heights. I feel proud that I feel proud that I'm being bestowed this presidency post by the well wishes and blessing of all my past presidents. It's a great responsibility on my shoulders to follow the golden footsteps of the stalwarts. But I am very much confident that I have a team. On the contrary, they are my family, I can say, who are behind me to guide me on this path, who are holding my hands. And I'm sure we can take IMA Dombivli branch to shine more and more. It is said that the strength of the team is the members, and the strength of the member is the team. So I request all my IMA family to be with me and guide me to take our branch to new heights. We had great plans to celebrate our Golden Jubilee year in a grand scale. But due to this gloomy pandemic, we had no other options but to have the conference on a virtual platform. Till date, I'm very much proud of all my IMA family and my members who were serving the patients in the COVID times with all grits and sincerity. Starting from the fever clinics in Shastri Nagar, infection controls in RR hospital, starting of the fever clinics. It is our brainchild of our own Dr. Mangesh Pate, and this Dombivli pattern of fever clinics was then followed all over India. We were in touch with constant touch with the local municipal corporation about the guidelines and further plan of action of COVID management, infection control, and creating a dedicated COVID health sector. Multiple lectures were taken by all our physicians, right from Dr. Archana Pate, Dr. Meena Pruthi, Dr. Vijay Lakshmi Shinde, Dr. Niti Upasni. We have conducted many community health programs, and we are targeting the adolescent age group under the Mission Pink Health. And not only the mental well-being was also been taken care, community-based programs about COVID in general were also being given to the college and to the community. We had to face a lot of hurdles in this gloomy pandemic. We have been attacked from all sides by the government, the media, the public, and certain our own fraternity members. But friends, we have become more stronger because of this opposition and hurdles. Dr. APJ Abdul Kalam, I remember the words of the great Dr. APJ Abdul Kalam. Difficulties in your life do not destroy you, but they help you to relieve, to see the hidden potentials in you. And so now let the difficulties and hurdles know that you too are difficult to be destroyed. Sorry. As a president of IMA Dombivli, I am proud of my team who our continuous guidance and of the advisory committee and Dr. Mangesh Pate sir. And we look up to them for the smallest of the doubts. The teamwork means divide the task and multiply the success. Team IMAFEST has a superb scientific session from the stalwarts in their field. There is a Upira oration which has been given to Dr. Raman Ganga Khedkar sir, who is going to be guiding us on the current pandemic. Sir is an ex-head scientist and epidemiologist from ICMR, and he is a Padma Shri awardee too. Our first IMA Maharashtra State Cultural Conference, Navrang, was inaugurated yesterday by our President, Maharashtra State President Dr. Avinash Pondwe sir along with lots of state and national dignitaries. We have been appreciated all over for the same. We, IMA, are always committed to our responsibility and stand up to any sort of crisis to our members, and we stand and make it a point that none of them face any issues in future. Let's continue our golden year further, wherein we will leave behind the footsteps for the successes to follow. Thanking each and every individuals, the delegates, the dignitaries, and my organizing team. Jai Hind, Jai IMA.
Thank you, sir, for a wonderful presidential address covering everyone's efforts and acknowledging their efforts. Thank you, sir. Now, now I will request our own Dr. Mangesh Patel sir to come on the dais and guide us. Aditya, can you have the slide, please? Dr. Mangesh Patel sir doesn't need any introduction. He is a patron, our own IMA member, and a true national leader. He is a pediatrician and neonatologist by profession, having his own Astha Hospital in Dombivli East. He is a chairman, IMA Hospital Board, Maharashtra State, a national treasurer, IMA Hospital Board. He is a member of IMA National COVID Task Force, national coordinator for healthcare accreditation, convener, IMA Headquarters Action Committee, convener, Standing Committee Against Healthcare Violence, national coordinator, Standing Committee for Vaccination, IMA Headquarters, member, Political Licensing Committee, IMA Headquarters, and all above all, he always hand for any doctor or any person in our fraternity whenever he or she needs. Please address as organizing chairman of this big event, IMAFEST 2020.
Thank you. I hope I'm audible.
Yes.
President of IMA Dombivli, Dr. Sunit Upasni, Honorary Secretary, Dr. Hemant Patil, Finance Secretary, Dr. Vijay Chinsoli, organizing team of IMAFEST and Navrang, and all my brothers and sisters from IMA Dombivli, and all fraternity members who have joined this online annual conference of IMA Dombivli, which has reached today to the great height. Because over last few years, IMAFEST and Navrang, they have become brand ambassadors of IMA Dombivli branch. Truly speaking, IMAFEST is a festival of Indian Medical Association. Our organizing team always try to give something so IMAFEST and Navrang, they have become a brand ambassadors of IMA Dombivli over past few years. Every year, our organizing team take tremendous efforts and they try to put forth the best possible lectures, best possible events for all those who attend this conference and this cultural event as well. This year, it is very special for the branch IMA Dombivli, being a golden jubilee year. IMA Dombivli has completed 50 years. 50 years is not a small period. During these 50 years, so many of our senior doctors, they have contributed to the branch activities, the development of the branch, and for helping the fraternity as a whole. Over past few years, our branch has raised its bar and we are now representing in the state and national level. And we are putting out our ethical and rational say in many topics which are raised at the state level or the national level. In various aspects, may it be related to the hospitals, clinics, laboratories, diagnostic centers, everywhere at the government level, at the civic body level, we are raising our voice. This everything was very much evident during the last 8 months when during the pandemic, it was IMA Dombivli which stood very firm and which guided the local civic body with the local political leaders and social workers that it is very much necessary to start immediately the healthcare in the viewpoint of the COVID pandemic. During that time, it was very great contribution from Indian Medical Association Dombivli branch to start the RR hospital to get it the infection control protocol or triage area or whatever it may be. Everywhere we have our physicians, they have stood and they have got it started. And the result is seen. Few weeks back, there was a poster all across social media that more than 1,200 patients have been treated very successfully at that center. But the pioneer of that center has always been Indian Medical Association Dombivli. Not only that, in the corporation hospitals, we have provided our doctors. Last 6 months, they have done the great job in the community clinics. On the sad note, this branch lost two of our very great members, Dr. Pankaj Kumar Chaudhary and Dr. Milind Vairali. I pay my respect and homage to both of them. As far as the working of the branch is concerned, are all stalwarts. The new generation which is coming in as the leaders, they are performing extremely well in the branch. So at the outset, during this Golden Jubilee year, I pay my absolute gratitude to the all seniors who have made this branch reach to this level. My absolute gratitude to that. This branch does hold a very bright future. Today, we have membership strength of around 400 members. Being a Golden Jubilee year, actually, this warrants a very grand celebration. Because of pandemic, we are limiting ourselves to the online this webinar and the conference. But I am sure our President Dr. Sunit Upasni and the managing committee, they will definitely come out with some solution for the grand celebrations of the Golden Jubilee year of this branch once the things. I again welcome you all. I extend my very best wishes and I declare this conference open, IMAFEST 2020 of IMA Dombivli. Thank you and good luck.
Thank you, Dr. Mangesh Patel, sir. You have always been a great inspiration and guide to IMA Dombivli managing committee. We, all the past presidents, are witness to this. And now I request Aditya to please play our inauguration video as our inauguration is already been declared. Thank you very much. That was a grand opening indeed. And now I welcome, we'll be beginning our scientific session. And I welcome our master of ceremony for the Saturday pre-lunch session, Dr. Ashwini Acharya, an eminent pediatrician who is scientific committee co-chairperson of IMAFEST. Dr. Ashwini, over to you. We'll be beginning our first scientific session.
Thank you, Dr. Niti. Na choraharyam na cha rajaharyam na bhratrabhajyam na cha bharakari. Yaye krate vardata eva nityam vidyadhanam sarvadhana pradhanam. It cannot be stolen by thieves, nor can it be taken away by the kings. It cannot be divided by among brothers. It does not have weight. If spent regularly, it always keeps growing. The wealth of knowledge is the most superior wealth of all. Good morning, all. A warm welcome to everyone. It's IMA's Golden Jubilee year. Our vision is to have a stellar conference, but COVID-19 happened. A few months back, we were worried even to venture outside. But today, we are brave Corona warriors. We take pride in accepting challenges and expanding our knowledge. We have arranged a great academic feast. Let's enjoy it. A request for members to log in with your names and please stay logged in till the end of all the sessions. Otherwise, MMC credit points will not be granted. When I was born, I was so small. They said I would not smile at all. My palate did not fully form. My lip on top was bruised and torn. But one day, to their surprise, I began to smile before their eyes. My mouth turned up, my eyes did shine. I defied them all and smiled just fine. The doctor spoke, their child is very strong. So don't you worry, it won't be long. And all is well, as soon as you will tell, the wait away will be a wondrous smile. Let's begin our first session. Smile is beautiful. The speaker is none other than Dr. Bharti Khandekar, who is the reason behind beautiful smiles of thousands of children with cleft lip and palate, and of course their parents. I thank Dr. Khandekar and Smile Train for being educational partner with us. Smile Train is an international children's charity that supports 100% free cleft lip surgery and care for children globally. I request our secretary, Dr. Hemant Patil, to be the moderator. Dr. Hemant does not need any introduction. He is known for his smile and dedicated work. He is consultant plastic surgeon at various hospitals in Kalyan Dombivli and his practice at Arno Clinic. He is an alumni of Sion Hospital and postgraduate from NHL Medical College, Ahmedabad. His special interest is in microvascular reconstruction, cosmetic surgery, and hair transplant. Dr. Hemant, please introduce our speaker.
Thank you, madam, for a wonderful introduction. Today, I feel very proud and honored to introduce our first speaker, Dr. Bharti Khandekar, madam. Madam is the one who actually pioneered the roots of plastic surgery in our area. I am proudly saying that when I came to Dombivli as a newborn in plastic surgery, I met madam and she has guided me wonderfully since then on every occasion. Her madam completed her MBBS and Master of Surgery from prestigious Grand Medical College, Mumbai. She did then pursued her MCH Plastic Surgery and DNB from Plastic Surgery from BYL Nair Hospital, Mumbai. He has done fellowships in clefts and craniofacial surgery from one of the best institutes in the world, Changgung Hospital, Taiwan. Fellowship in maxillofacial trauma from National Institute of Singapore. She is also the project director of Smile Train Cleft Center. Her enthusiasm and thrive to treat children with cleft lip and palate to bring back the smile and confidence in their life is really great. So she has continuously taken tireless efforts to establish a Smile Train Center in our region, which itself is a mammoth task, but she achieved it wonderfully. So let's listen from Dr. Bharti Khandekar, madam, about an art, we call it as plastic surgery. Over to you, madam. Madam, unmute yourself.
Just 1 minute.
Visible, it's visible.
Yeah. thanks Hemant for, can you hear me? Can you hear me?
Yes, ma'am.
Yes, ma'am.
Yeah. Thanks Hemant for your kind introduction, and good morning to all of you. And I will begin with my talk, that is Smile is Beautiful. First of all, I would like to thank IMA for inviting me to deliver this lecture. Restoration of this subtle mechanism of smile in case of a cleft patient requires a ultimate in surgical precision and artistry. These children which are born with cleft lip and palate, this is a very common congenital anomaly, 7 per 1000 live births. It is the commonest anomaly found in India, and that there are different causes. The most common cause with these patients is the vitamin deficiency, that is vitamin B12 and folic acid deficiency. And this, most of the times in our antenatal program, what we usually start with this supplementation is after the conception. But the females, before their conception, should be started with these vitamin supplements to avoid such kind of deformities. Now, I'm beginning with my very simple type of a classification which will be useful clinically. In congenital cleft lip and palate, we can classify them as those children which are having just cleft lip, those with cleft lip and cleft palate, and those with cleft palate alone. This cleft lip can be one-sided when we call them as unilateral. In unilateral also, the severity can vary from incomplete cleft lip to complete cleft lip. And the bilateral, where the cleft lip occurs on both the sides. This is a very simpler classification. Actually, there is varying degree of severity in these children depending upon the underlying deficiency of the tissues like bones, skeletals, hypoplasia of the soft tissues. So there are different classifications, sub-classification, but for the understanding, I've just made it very simple. Even cleft palate, which actually deals with the our speech part, this cleft palate can be incomplete, complete when it extends anteriorly till the level of an incisive foramen, or it can be a submucous cleft palate, where you can see it in the third photograph. This submucous cleft palate is, most of the times these patients, they come very late because they are not diagnosed early, and hence the golden period is most of the times missed with submucous. In each of these deformities, you need to modify your surgical planning. Now, what is the protocol for cleft management? First of all, what is more important in any cleft management is it is not a single person's efforts. It is a teamwork. And this team comprises of pediatrician, anesthetist, plastic surgeon, orthodontist, speech therapist, coordinator, and the counselor. Counselor can be a surgeon, and each and every person is actually counseling the patient's parents. Now, what is, for the simpler reason, I have just classified into surgical management. Now, lip repair and nasal correction is done from 3 months onwards. This primary nasal correction or a nasal correction is decided as per the severity of the deformity. The palate repair, the ideal age for palate repair is 9 months to 1.5 years. The nasal correction, which I have mentioned over here, is when the deformity of the nose is very severe. You might require an additional corrective procedure in cases of unilateral cleft lip, or in cases of bilateral cleft lip, when the columella or the central portion of the nose is not sufficient, we need it to be lengthened. So that can be done before child goes to school. Then the alveolar bone grafting. Alveolar bone grafting means a gap is there between the dental arch, and that needs to be grafted with a cancellous bone graft so that the canine can erupt through this gap. And this is the foundation which is required for your orthognathic surgery or a jaw surgery. Then orthognathic surgery and rhinoplasty, in each and every case you don't require it. It depends upon the deficiency of the underlying skeletal work and the nasal tissues. So this is done after maturity. Now, what is the protocol for nasal correction? What I have previously mentioned, the cleft, if you label just as a unilateral cleft lip, it is not sufficient for a surgical planning. What surgical planning is dependent upon the deficiency or the substance which is underlying the cleft. If you see the first cleft, which is very incomplete, which is very mild in variety as deformity goes, where both the base of the nasal, base of the alley are at the same level. At the same time, if you see the second picture, where there is a severe deformity, where there is a severe antero-posterior deficiency, means the alloy on one side is at higher level and on the other side it is at a lower level. So your nasal correction and your results are related with your degree of severity. For understanding purpose, this is an alveolar cleft, that is the gap between the teeth, and this needs to be closed with a cancellous bone graft between the ages of 7 to 9 years, and this decision is jointly taken with the orthodontist. After seeing the orthopantomogram, we decide whether we need to first do the expansion or we need to first do the graft and then expand the arch. I will come to that point later on. Now, what is the protocol in cases of orthodontic management? I have purposely put this slide because most of the times a surgeon, or when the patient reaches a surgeon, most of the time everybody is bothered about the surgical planning. It doesn't end over there. There are two main important people who always give you the best result. One of them is orthodontic. Now this orthodontic begins from the first month after birth. Now I would like to proudly want to say that ours is the first center in Mumbai which has started with this nasoalveolar molding. Now what exactly done? If you see the first photograph, the nose is totally flattened. The gap is wide. With the help of a nasoalveolar molding, it is kind of a appliance. With that, what we have got is a gap is reduced. The nose has become better in shape. And if you see in the third slide, this is the result which is stable for 6 years. Getting an immediate post-op best result is not something difficult, but having a stable result is very much important whenever you are dealing with cleft deformity. And I am very proud of my orthodontist, Dr. Himanshu Dave, who has helped me for last 20 years. Now, this is what is the another thing where the orthodontist come in the picture. This is what we call it as, if you see, the upper jaw is collapsed inside and the teeth are not aligned properly. This is, if you the second photograph you see, arch looks very much neat, totally aligned, and the jaw has come forward. This is the another photograph where we usually, when a child is having a severe jaw discrepancy, means the upper jaw is far ahead and the lower jaw is far behind. We call it as a class 3 kind of a malocclusion. And when the child has not attained maturity, we cannot do any surgical skeletal work. The orthodontist helps us to get this upper jaw in position with the lower jaw, and the child, whatever inferiority complex usually he is having because of his appearance, is reduced a lot. And thanks to the orthodontic for this. Now then comes to a very important aspect, speech management, a cleft palate done by best surgeon without a speech therapy will not get that result. Hence, a speech management is the mainstay for your palate surgery. And this speech pathologist, I again thank my speech pathologist, Sucheta. She has helped me a lot for last almost 6 years. This actually comprises of 3 things. First thing is parents should be continuously counseled about it, that they need a speech therapy, it is must, because usually what you get is a good compliance for the surgical procedures, but for speech, very few of them turn up. So parents counseling is very important. The mother will guide her in such a way that she becomes the special educator. Then the language stimulation part comes from about 1.5 to 2 years. And then the speech therapist vigorously work on the articulation errors to give a speech which you hear near normal. Now, why a patient or a child should go to a cleft center? What is the advantage of going to a cleft center? Now, as I have already said, the cleft management requires a dedicated team approach. The coordinated efforts only gives you best results. There is different variation, there are different degrees of severity of cleft. Hence, modifications are required to get the best results. For each and every case, the planning is not same. If you use, whenever I do my lip surgeries, in each and every case, I take all their anthropometric measurements. Then I decide how I should modify in such a case. So your planning changes with case. And statistics, the scientific material, it helps us to evaluate and modify our surgical procedures regularly. Now, most of these patients are very poor socioeconomical class. And if you see each case with a complete cleft lip and palate, usually has to undergo minimum of 4 primary surgeries. And this puts a tremendous financial burden on them. So they need a help. Another thing is, most of the times, everybody is busy with the surgical procedures, and orthodontic treatment and speech management are always at the back seat. So now, what is the unique approach? I have started my Smile Train Cleft Center. Actually, when I approached Smile Train to start a center, they were very much not very happy to start in a remote area because it was not accessible to them. But my only thing was that most of my patients, when I was in Godrej or when I was at Wadia, were from this area. So rather than it is not accessible to us, it was very much accessible to the patients. And that was my reason to start this in our area. And I'm very thankful to Smile Train that they have responded to my each and every demands, whatever I asked them, for the benefit of the children. Now, these children are usually malnourished. What we do, we provide them a nutritional support and educated mothers on feeding. We encourage breastfeeding in some cases, and that is with the help of videos, it becomes easily for them to understand. In the first visit, the child is examined by the pediatrician and the anesthetist. I again thanks my anesthetist, Dr. Poonam Bhadlikar, who has supported me very well. And in my initial Smile Train work, Dr. Kala and Dr. Pallavi has also helped me a lot. But now for my whole cleft surgeries for the last almost 3 years, Poonam is all the time there with me. And it has given me a very safe post-operative phase. Now this pediatrician and the anesthetist, they usually try to rule out any other anomalies. Again, Ashwini, I'm very thankful to Acharya sir. He is responsible for fitness of our all children. Now, most of these patients are from very poor socioeconomical class. And I am very much grateful to Smile Train organization that they have not provided us only with free surgeries, but ours is the only center where orthodontic and speech therapy is also totally free. We give them travel expenses. In case of parents who are with daily wages, we give them financial help. So when they are absent from their work. So the whole purpose is that the child should get what is ideal. And we don't want to promote our center that the children should come here because they get the best results. And that is whole purpose behind this center. Now we arrange regular workshops for speech therapy. In the first picture, you can see Suchetao. She is delivering the lecture. We call the guest also to deliver the lectures from Bombay. Basically on speech therapy, orthodontic treatment. Now here we usually discuss the individual cases and where we have got good results and what are the reasons behind that. It is for the parents' motivation, and the children also are treated and they are celebrated with when they achieve something. We have recently celebrated one of our patient who has scored 96% in SSC exam, and she came first in a singing competition, which is in case of a complete cleft lip and palate patient is really a creditable thing. Now, what is another unique approach to our center? During this period, I was able to visit many of the Adivasi padas, and I have found whatever their intentions may be, but still it is very difficult for them to reach health centers. Health workers and NGOs, we provide them. I myself go there and visit them, and we give them nutritional support, whatever nutritional supplementations are there, and we travel to reduce their travel only for the purpose of surgery, and the follow-up care is taken at their place. Now with all these things, still, though it is not very common, still I'm getting unoperated adult clefts. These two patients were in first case, if you see, that the lip is not operated, and in the second where the palate is not operated, these patients were not able to reach the government or the municipal organization because of the distance part, and because they don't get any financial help and remain unoperated till childhood, still adulthood. Now, these are the few of the results which I would like to share, because my whole purpose is always that you should come to our center because we offer the best, and we are always involving the new procedures, and we want to get the best results with a team approach. These are few of my results. And I'm really thankful to IMA Dombivli for giving me this opportunity to deliver this lecture. Thanks.
Thank you, madam. Thank you for a wonderful presentation as your surgery is. And believe me, all those who are watching, it is really what looks in a picture. It is very, very difficult job when you put the knife on palate and try to move that palate even for a 5mm job. I know as a plastic surgeon how difficult it is, and madam, you are really doing a commendable job. I would like to ask a few questions, madam. Just although you have elaborated it on the slides, but there is very common question that people come to us and ask that when they bring the child to a doctor, even many doctors don't know how to guide them. So can you just briefly tell what a general surgeon or say a general practitioner, there are many in our field, how they can guide people to your center and what age specifically to guide?
Previously, people used to send us at the age of 3 months because the lip and nasal correction is done at the 3 months onwards. But now I always tell them to send it immediately after birth, because first thing is that we have got a nasoalveolar molding, which is useful only in the first month after birth. That is first thing. Second thing, parents need a counseling. They are always psychologically disturbed because first of all, there is some guilt. There are many questions. And when they come to our OPD, when there are around 20 to 30 patients around, they realize that they are not alone fighting the battle. There are many, and they can visibly see the results. So I will tell you that once the child and the mother both are fit, you can immediately send them to our center so that we can guide them regarding what are the things, what is the protocol, and we always reduce their stress levels.
Madam, one more question. It is also very common that
Yeah.
people have already operated the lip and palate, and due to the
Yeah.
shorter length of palate, they have a nasal
Yeah.
twang. So people are under belief
Yeah.
that this has not been corrected well. So can you just
Yeah.
elaborate upon the velopharyngoplasty and that what can be done at a later
Yeah.
age?
Yeah. Yeah. See, here again, one thing is there. What I have said is the severity of the cleft palate. Severity doesn't mean only it is incomplete or complete. Severity means even if the muscle is not fully developed, if it is hypoplastic, if the palate is short, then also you will have a velopharyngeal discrepancy. Means the distance between the uvula and the posterior pharyngeal wall, if it is more after repair, you will have a nasal emission.
Yes.
So there are this, usually what we do is that I always send them to speech therapist. So speech therapist evaluate, we take the speech recordings, and after that we decide that how much amount of lengthening is required and what is the type of a defect. We do a nasoendoscopy, which tells us the type of the defect, and depending upon nasoendoscopy, we decide our further surgical planning. Another thing which I would just want to tell you is that most of the times when this patient goes for a jaw surgery, where the upper jaw has been taken forward, in those cases, there are always chances that the speech might get deteriorated because the velopharyngeal incompetence can occur. So whatever the decision which is taken is always a joint decision in the benefit of the best result for the child.
Thank you, madam. I think just to sum up, I will like to say that cleft lip palate surgery is a big symphony, and it sounds really well when it is headed by a true plastic surgeon. Thank you, madam. Thank you very much
Thanks
for
a
your
lot, Hemant, for
great
giving
guidance.
this opportunity. Thanks a lot.
Yeah. Thank you, ma'am. Now I request Dr. Ashwini Acharya, madam, to take over, please.
Thanks, Dr. Khandekar, for enlightening us, and thanks, Dr. Patil, for moderating the session. Now, we would like to felicitate our speaker and the moderator.
Thanks a lot.
Please accept our e-mementos.
Yeah.
I thank again Dr. Khandekar and Smile Train for being educational partner with us. Dr. Niti would like to have a few words with us. Yeah, please felicitate our moderator and present e-memento to him.
Thank you, madam. Thank you.
Thank you, sir.
A really nice moment. Thank you.
Now, I would like to request Niti to have a word with us.
An excellent scientific session. We'll be continuing with our scientific session, but there are a lot of questions regarding people are not able to change the name from their device. Friends, absolutely don't worry about it. You can put your name and registration number in the question and answer option, which is available every 1 hour or so. We are keeping note of that question and answer session note where the names are being displayed. So those who are able to change the name to their login name, it's okay. But if it is not possible for you to do that, we have taken care of it. You will have to put in your name and registration number in that question answer session option every 1 hour or so. So just don't panic. We are going to credit the MMC point to everyone, but the names and MMC number should be there everyone. Thank you very much. We will continue with our next session, scientific session. Over to you, Dr. Ashwini.
Thanks, Dr. Niti. Our second session. Life is a journey, death a destination. Palliative care is an approach that improves the quality of life of patients and their families for facing problems associated with life-threatening illness. Nothing is more caring than relieving their suffering, be it physical, psychological, social, or spiritual. While end of care is still often viewed as care provided by specialists, ideally it would start at an early stage with an important role played by family physicians. Our next topic is end of life care, family physician's perspective. It's our privilege to have Dr. Rup Gurusahani as the speaker. Dr. Kirti Patil is moderating the session. Dr. Kirti, she is a consultant neurologist at Arnav Clinic, Dombivli East. She is an undergraduate from Sage GS Medical College and DNB Neurology from Hinduja Hospital. Her special interest is in Parkinson's disease, movement disorders, and Botox therapy. We thank Sun Pharma for associating with us as education partners. I request Dr. Kirti Patil to introduce Dr. Rup Gurusahani.
Thank you, Dr. Ashwini, for nice introduction. A very good morning to everyone. Respected dignitaries and senior members of IMA, I thank you for inviting me for moderating this session. It is really an honor and privilege for me to introduce my teacher, my mentor, Dr. Rup Gurusahani, consultant neurophysician at PD Hinduja Hospital and Research Center. He has been a part of FINE, Forum for Indian Neurology Education. He has been associated with epilepsy clinics on Lifeline Express run by Impact India Foundation, the world's first hospital on train for underprivileged people of rural India. He is an active member of ELICIT, End of Life Care in India Task Force, which is joint initiative of IAN, ISCCM and IAPC. It is interdisciplinary task force of intensivists, palliative care physicians and neurologists for end of life care in India. All physicians and general practitioners often come across terminally ill patients with a big list of problems, what to expect, how to counsel such patients and caretakers is list taught in our books. Today, Dr. Gurusahani is going to talk about these issues in palliative care. It's a great pleasure to have you, Dr. Gurusahani, and we look forward to your presentation. Over to you, Dr. Gurusahani.
We will be with you soon. There are some technical issues. If people can't put their names on their mobile as ID, please don't worry. You can put your name and MMC number in the chat section. We request you to put it every hourly or so that we can keep a track of people who have attended the whole academic session. If you have any doubts, you can call the registration team. We will guide you. Thank you.
Hello.
Yes, sir. Welcome you, sir.
Hi. Oh, nice. Lots of participants.
Sir, you can start the presentation.
Okay, just give me a minute.
Yeah.
Yeah, so you see my screen? Yeah.
Yes, sir.
Yes, sir. We can see.
Sorry, I'll just have to. Give me a minute. Huh?
Sir, in the top right, present option.
Yeah, no, not that. I was doing it from Google Slides, but I thought I would change it and do it from what I have downloaded. That makes life a little easier. Where is that from? Yes. Got it?
Yes, sir.
Okay. Right. So, thank you, Kirti, for thinking of me and for inviting me. For those of you who don't know her, Kirti Barambe is my colleague from Hinduja Hospital. She's a neurologist who practices in your area, but I'm sure I don't need to introduce her to you. So, but I would also like to start by thanking Dr. Upasni, Dr. Pate, and Dr. Patil for inviting me to speak on something that is now very close to my heart. Okay, so end of life care. I was asked to speak on essentials for the family physician and the internist, as I was told. And I'm going to cover actually 3 areas in this. Yes, my involvement with this topic began. Can you hear me clearly, everybody? Am I audible?
Yes, sir.
Okay.
Yes, sir. Yes, sir.
Yeah, my involvement with this topic began in March 2011 when I was invited to be on the medical panel that looked at Aruna Shanbag's case. And this was followed by a judgment which got a lot of coverage. But as time went on, my realizations evolved, and I began to realize that in spite of that judgment and what followed, as a citizen, I would really have no control over my own last days. And as a neurologist and a physician, I could not help my patients till the last. And so often, as I suppose you would also have realized, we are forced to say, "Ab main kuch nahi kar sakta." So something was missing in my professional capabilities. And this talk will tell you how we've gotten along on that. Now, end of life care has multiple strands. There's ethics, there's legislation, there's politics, there's complex medical decision making, but you must never forget that at the end of it, there is individual human suffering. And whose business is this? The government, us as the medical profession, the lawyers, civil society. And as you realize, everybody's business is really nobody's business. So in 2015, 3 national medical associations, neurology, critical care medicine, and palliative care, came together to form what we called the End of Life Care in India Task Force, ELICIT. And we have been involved with this topic significantly since then. The 2 gentlemen to my left are actually my mentors in this field, Dr. Nagesh Simha and Dr. Raj Mani. And you may recognize some of the others there. And one of the first jobs that we did was to prepare a basic end-of-life care law for India. And that law, we thought, had 3 major components that needed to be covered. One is confirming patient autonomy. Remember that although our constitution gives us liberty, liberty is a political right. To bring it into the personal space, especially into that of healthcare, actually required a specific validation. Then, due process for resolving medical futility issues when we need to withdraw. And uniform recognition of death. Some of you may be aware that brain death till now seem to be recognized only for the purpose of organ donation, not otherwise. And this law had due safeguards. It had no financial implications, so the government would not really need to spend anything for putting into action. But unfortunately, there is very little political interest, and you can understand that. Governments that may not have done too much about healthcare will not take on a death law because the opposition will sit on their chest. So we think that perhaps some state governments may do this, but this is going to be a long process. In the meantime, does this mean that nothing has happened? I can do what I want? No. And I'll explain to you what the legal position is now, and this may be different from what you have heard earlier. So please pay attention. In 2018, on the 9th of March, a writ petition judgment was delivered. This is called the Common Cause versus Union of India, which actually said that patient autonomy was a right. It had its basis in the rights of autonomy, dignity, and privacy, and it followed on from the privacy, that is the Aadhaar judgment. It provided a constitutional basis for the living will, that is advanced medical directives, and for withdrawal of life-sustaining treatment. And it prescribed a procedure with safeguards and guidelines. But what they said is something that we all need to hear. All adults with capacity to consent have the right of self-determination and autonomy. A competent person has the right to refuse specific treatment or all treatment, even if such a decision entails a risk of death. The emergency principle can be given effect to only when it is not practicable to obtain the patient's consent. But where a patient has already made a valid advance directive, such a directive has to be given effect to. So the thing is that this judgment then went on to say that if somebody has not made an advance medical directive, then also they should have the same right of withdrawal of life-sustaining treatment. It said that the medical decision making has to be done by the treating team, but they added one more layer, which is a district collector, a government committee. And unfortunately, that government committee is something that has spooked everybody. And literally, I have no knowledge of any case anywhere in the country which has followed this whole process. They had not made any further mention of a form for the living will. So our group went ahead and prepared this form for Indian purposes. This is actually pretty simple. We've kept it rather simple. We've looked at 3 situations where this should come into effect. We've again requested that it should be confirmed by 3 doctors, and it applies to all these life-sustaining treatments, which you can tick or you can cross. If you say you want one of them, don't want the others, that's fine. But if not, then all of them you are assumed to have refused. And this has to be to secure compliance, you appoint what are termed as surrogate decision makers, or effectively a healthcare power of attorney, and you need to have at least ideally 3. Now, this declaration remains in force, but it can be withdrawn and nullified orally at any time. To make it, it has to be in writing, but nullification orally also. It requires witnesses. The appropriate authority as of now is the judicial magistrate first class. But we hope that will change over a period of time. And this document is available on the following websites, and you can get it downloaded from there. Please do not be surprised if someone turns up in your clinic with one of these documents. So that is the next. The third thing that happened is that towards the end of last year, if you remember, I had said earlier that brain death could only be declared for organ donation. Well, that changed. The government of Kerala via a government order, and then the government of Karnataka de-linked brain death from organ donation. In fact, Kerala says that at least in the government hospital, if somebody is brain dead, then they must be removed from the ventilator. And this is important because a lot of us seem to believe that that is illegal. Well, in the sense that it has not been written so for Maharashtra, but it is already in process elsewhere, and we need to keep that in mind. Then in April this year, this paper appeared. I was part of this. These are the ICMR consensus guidelines on do not attempt resuscitation. And it says that is the patient at risk of arrest? Does CPR have a realistic chance of success? And I'm going to take this no, not sure first. If it is no, not sure, you have to actually either inform the patient or the patient's relative, take the patient's values, choices, take decision in the best interest of the patient. And if the patient says no, do not, or the surrogate says no, do not attempt resuscitation. But that does not mean that you stop care. Supportive and compassionate care continues. What about a patient who may have a reasonable chance of resuscitation? In this document, well, we were not in agreement, but it was said that CPR should be done, which actually is a little tricky. Because if you look at the judgment on which this was based, well, the judges actually said that if somebody says no, you have to follow that. So the point that we made, and this paper is free on the net. It actually has a DNAR form which you can print and which you can use. The point that was made is that CPR is a procedure. If a procedure is expected to be performed, it must be consented. This is good medical practice according to the ICMR. Then came the All India Institute of Medical Sciences guidelines. They published this in by about June, signed out by the director, and they gave a whole pathway for management of futility. And they included various forms. Now, AIIMS is a statutory body, so any hospital is entitled to take those down and use them. They actually made a sequence of surrogates who could be taken in case the patient had not identified it in writing earlier. Actually, before AIIMS did that, this had already been done for the private sector. This is a document that was prepared for the Manipal group, and it is already in use in the Kasturba Medical College. Remember that for the private sector, futile care at the end of life, when a family gets back a dead body and debts, they presume malified. And we must recognize futile treatment. Now, a lot of us think that cases will come against us if we do not do everything. That is wrong. In the West, the maximum end-of-life care litigation is about excess treatment, wrongful CPR. The first case that has actually gone against a hospital was because they kept somebody who was brain dead alive, and this hospital in Delhi was fined 5 lakhs. You may have already seen this case. It didn't become a case, but there was a fair amount of publicity against Bhatia Hospital. And please remember, Dama Lama is not a safe shortcut. Fortis Hospital is in trouble. Because of that, as per Lama guidelines, a hospital actually has to transfer a patient from life support to life support with an appropriately equipped ambulance. So the Dama situation of putting the patient in an ambulance, extubating there, and letting the patient die and then saying, not in my hospital. Sorry, somebody is going to get into bad trouble with that. So, what is it that I'm saying? No law doesn't mean nothing. You cannot do what you want. But this is an evolving situation. Please tread carefully. If you want to say that until there's a law, I will do what I want, you will get into trouble. Okay. So, as a citizen, yes, it's changing for the better, and I probably will have a lot of control over my own last days, hopefully. But the other part of my question comes up. As a neurologist and as a physician, how can I help my patients till the last? For this, you need to understand the trajectories at the end of life. So you have this paper that came out quite a while ago, which looked at trajectories at the end of life, and it captured 92% of all deaths that were sampled in that particular series. So it looks at how we die after the age of 50. After the age of 50, less than 10% of people die suddenly. Remember, our long-haired president, he had done a lot of punya, and that is why he got a death of that kind. I'm not sure that all of us have done so much punya. For most others, it is one of these routes. So for people who get cancer, and this is typically in the 60s, this is called the waterfall trajectory, where after the malignancy becomes terminal, there is this consistent decline to the point of death. And this accounts for about 20% of all deaths. What about organ failure? When somebody has hypertension, diabetes, renal failure, COPD, so on. This is called the looping trajectory, where people come into hospital, come out not as good as before, back again, in, out, and then finally pass away. This accounts for about 15% of all deaths. And since VIPs usually get transplants, this is the common man. And then you have frailty and dementia, simple old age, people who are as it is at a low level of function and keep dwindling away. This is called the dwindling trajectory, affects about 50% of us. And remember, Atal Bihari, we last heard him after he lost the 2004 elections, and finally he passed away in 2018. This is a very long trajectory. And for neurologists, there is yet one more trajectory that is being defined, and that is of somebody who was completely normal, has a what we call a severe acute brain injury, and then either dies or reaches a persistent vegetative state, or very likely improves with significant disability, and then follows one of the other trajectories that I told you about. So after the age of 50 years, for about 85 to 90% of us, death is predictable, some weeks or months before it occurs. And it is our business to make these predictions. So there are three triggers that we should not miss that somebody is in their last year. The first is a surprise question. If you as an experienced clinician are intuitively asked, would you be surprised if this patient were to die in the next few months, weeks, or days? And you give an intuitive answer, no. It is likely to be, depending on your age and experience, it is likely to be anywhere between 60 to 80% accurate. And it's an intuitive answer. And it has been proven statistically. Then, if somebody is going down gradually, and somebody who was walking, talking is now bed or chair bound more than 50% of the day, needs more and more support for self-care and so on. Those are indicators of decline that may not be obvious to the patient or even to the carers. And then, of course, you have specific indicators linked to diagnosis like COPD, FEV1 less than 30%. With all of these, please remember that 100% answers are not possible. We all have to accept uncertainty. But if you look at it, this is one statistical tool that is used for predicting one-year mortality. If you look at these indicators, and if you count, say, for instance, say you have a male who needs complete assistance with everything. So 1 plus 2, 3, with all ADL, 1 plus 5, that is 6, and also has congestive heart failure, 8. Anything more than 6 points, a one-year mortality is more than 60%. So you can understand that 1 year plus 1 year plus 1 year, more than 90% chance of not surviving beyond 3 years. So how do you manage this kind of situation? I borrowed some slides from Pallium India, and I'll explain that to a little further. So beyond that, what about active dying? Now, this is the period just preceding death, during which the patient's physiological functions wane, and you need to prepare the family and caregivers for the natural process of dying. And the care has to be multidisciplinary, holistic. How do you know this is happening? This is a purely clinical judgment. Why clinical? Because if you make this diagnosis, and actually investigating them adds to their burden. So this is somebody whose ambulation is going down, becoming withdrawn, oral intake is going down, fatigue is increasing, weight loss is increased. And this happens months to weeks before death. Then in the weeks to days before death, blood pressure starts to fall, the pulse becomes a little slow, drowsiness, delirium comes up, and the patient is completely confined to bed. And in the days to hours before death, in addition to decreasing consciousness, you will get chain strokes breathing, you will get the harsh sound of secretions called the death rattle, cool, clammy extremities, the face may relax, and often the face shows a yellow sallow appearance. Now, as a neurologist, I'm involved with a lot of these situations. As I said, this can be catastrophic brain injury, these can be terminal illnesses, including neurodegenerative, and all life-limiting neurological illnesses, including Parkinson's, progressive MS, dementia, but also organ failure. Very often, neurologists are called in because metabolic encephalopathies happen in these situations, and very often nobody else is willing to bell the cat and give the prognosis. So when somebody gets a life-limiting illness, as physicians, from the time of diagnosis, we know this is going to happen. Okay, and unfortunately, our usual response is like this airline pilot together with the stewardess who's taking this parachute and jumping off. अब मैं कुछ नहीं कर सकता. Why? Because we were not trained for this, and the lack of training make us uncomfortable to the point of abandoning our patients when they need us most. We lack training in prognostication, communication skills, symptom control, and we forget the number of our patients who, well, they just stop following up, and we don't even know when they die. If you look at the average GP's workload in the UK, average 20 deaths per GP per year, and their numbers are much smaller than ours. So obviously, we are not seeing a lot of these patients. So let me tell you a story. On a Sunday last year, a 92-year-old gentleman, a patient of mine, passed away in his own bed, surrounded by 4 generations of the family. A week before that, he had come into our casualty, fetal position, stertorous breathing, unresponsive, distraught son and daughter. I had diagnosed him 5 years before that, but he was following up the colleague who had just told them, "Ab main kuch nahi kar sakta." And earlier those words would choke me too, but I had no choice but to say them. But now my residents know what to do. So she told, "We will admit, but for a maximum of 4 to 5 days, we will make sure he has a peaceful and comfortable passing, and preferably back at home." So he was admitted, he was given IV fluids and antibiotics. Palliative care was called in. They confirmed that he had begun to die. And then they contacted the family physician who was brought into the loop. And 4 days later, he was awake. He couldn't speak because he had lost speech. And his granddaughter was there. And she said, "Why are we not feeding him? Why are we not putting in a rice tube?" So we again had to explain to her, which we had already done to her father, that eating difficulties are part of the natural progression of dementia. Feeding tubes do not enhance survival or quality of life, and careful hand feeding is preferable. So the line that I usually use is, "सेवा ट्यूब से करोगे? उन्होंने आपको हाथ से खिलाया था, अब आप उनको हाथ से खिलाओ." And this is something that is documented, that when you put in a feeding tube, patients pull it out, so you have to tie them down, and everything becomes a mess. So much better to feed them by hand, and whatever has to happen will happen. So he was discharged without an RT, and he passed away at home a few days later. So Dr. Raja Mayyar, one of our palliative care physicians, she was in touch, and the family actually was very, very grateful that they had the chance to offer seva at the end. So palliative care actually is applicable to all serious health-related suffering. End-of-life care is a small part of it, and then comes terminal care and actively dying processes. So if you look at palliative care, it is specialized medical care for people with serious illnesses. It is focused on providing patients with relief from the symptoms, pains, and stresses of a serious illness, with the goal of providing quality of life for both the patient and the patient's ecosystem, the family, also the family doctor if possible. And we provide it through a team of doctors, nurses, who work with the patient's other doctors to provide this additional layer of support. It is appropriate at any age, any stage in a serious illness, and it can be provided together with curative and life-prolonging treatments. So end-of-life care is an approach that shifts the focus of care to symptom control, comfort, dignity, quality of life, quality of dying. And it can be done at the home or in a hospice. Now, I'm not qualified in palliative care, so I depend on Hinduja hospitals to consult in palliative medicine, Dr. Jayarajam and Dr. Raja Mayyar, and you may know either or both of them. What do? They speak to patients and families. Palliative medicine is talking medicine. And if you are not capable. This doctor at least recognizes that he cannot talk. I mean, he cannot communicate. So he's passing it on. Why is this important? When we emerge from medical college, everybody can talk. And this is the Dunning-Kruger effect, which has been shown in a lot of skilled, in a lot of skills. So when we know nothing, we rapidly have a very high level of confidence. And that's called being at the peak of Mount Stupid. With experience, we realize that we don't know anything and we end up in the valley of despair. So one of my neurology colleagues, his point was, I don't talk to the relatives, my juniors do. And this was from a senior colleague of mine who spent 1 week talking half an hour every day to the patient's husband. I spoke to him for only 10 minutes. Anyway, unfortunately, there is no app for communication skills. And communication skills have to be learned, like surgical, diagnostic, administrative skills. It needs training, it needs practice, it needs assessment and certification, and then you can become a guru. And even then, you have to keep on preparing, proceeding, doing a review with every time you perform it. But obviously, it gets simpler and simpler as time goes on. And if you think that you are the master of communication skills without having gone through this process, I'm not going to tell you which of these two you are. Okay. What else do palliative care physicians do? They control symptoms. Remember that symptom burden in neurology patients is as much in oncology patients, but our patients have no voice. And most of non-oncology, almost 50-60% of non-oncology palliative care is related to neurology, which is something that is a separate topic by itself. And there are various symptoms that our patients have, both in oncology, and they overlap. And if you look at all of these symptoms, you will say, we manage all of them. No, you do not manage them systematically. Evaluation, explanation, management, monitoring, attention. All of these have scales because these are in some ways a little vague to manage. Somewhere they are between doctors and nurses. They need systematic management. The commitment of palliative care is to add life to days and not days to life. So I've already told you this. Remember that when I qualified in medicine and then in neurology, well, in medicine, we refer to nephrology only when the creatinine costs 10 because dialysis equal death. Now we refer at creat 1.4. When I qualified in neurology, we had no intensives. So we used to intubate and ventilate and make a mess. Now, no way. So think of a specialty that can dialyze your patient's family's mind and intubate your patient's soul. And sooner or later, you will need to refer. So my realization of what was missing in my professional capabilities was the realization that I had been trained in curative medicine, which seeks to return patients to their own lives so that they can do what they want. Palliative medicine seeks to assist patients in leading their lives, supporting them in the pursuits that they wish to prioritize in the time that they have left. So basically, palliative care comes in to provide care when cure is not possible, and it gets an increasing amount of importance as you proceed from diagnosis towards the end of life and even beyond. Now, I was asked to speak on end of life care, and we are 6 months into a pandemic and we still have no clear sight of the end. So let me put this in perspective. These slides also are from Pallium India because this is an online course that I am also a part of. Why is end of life care so important? Well, in India, one of the things is that we in India are actually pretty bad. In 2010, when this quality of death index was first done, we were at the bottom of 40 large countries. Then we improved in the next time it was run in 2015 because they found about 13 countries that were worse than us. And if you look carefully, both China and Pakistan are worse than us. So we can be happy about that. What are the relevance and challenges of end of life care in the context of COVID-19? Acute illness, limited information, information overload, isolation, lots of PPEs. All of this comes into play. But you need a plan, and with a plan, you can actually handle these situations. You need to have a goals of care discussion of the family, transit from intensive care to palliative care, and then go on to bereavement if need be. So the important thing is to ensure patients' comfort through appropriate symptom control, and you refocus medical and nursing care, avoiding unnecessary interventions, review all medicines and symptoms regularly, maintain effective communication, and provide psychosocial support for the family members. The common symptoms that we deal with are these: breathlessness, agitation. I'm going to run through these slides a little quickly because, as I'm going to make clear, I think this is a course that a lot of you can take. What about breathlessness? 1 minute, I'll be done. Yeah, breathlessness. Well, morphine, midazolam, both can be given both IV as well as subcutaneously, and it's not very difficult to do. For agitation, we use haloperidol and midazolam. For pain and fever, you can use paracetamol, go up to a maximum of 4 grams in somebody who doesn't have hepatic disease. Secretions, we avoid suction, we try and do position change, we use anti-sialagogues like glycopyrrolate, but do it in moderation because dry mouth is actually even more uncomfortable. And we make sure that these patients do not get pressure ulcers by attention to pressure areas and skin care and so on. For more details on these online courses, I strongly recommend that you look at this website, palliumindia.org, online training, and you will find things that you can easily do. But we have one more responsibility as clinicians who can influence the way medicine is organized around us. You have to push to set up palliative care in your area, in your institution. They will help with the care of severely ill patients over time, help with discharge planning. They help with complex consent because they can help patients, families, clinicians make decisions, set goals of care. They can find solutions for future planning needs in advanced illnesses, and as I said, manage symptoms. But personally, all of us have to make this commitment. You have to be prepared to foretell. If you do not commit to foretelling, your prognostic skills will inevitably atrophy. Because it's only with this that you can answer these questions. How long have I got? How long will she suffer? Patients are asking these questions. We are ignoring them. We are looking away. You can communicate honestly, accurately, and with optimism. It's a little tricky, but if you learn communication skills, you can do it. And then the last question that will come up. If I do not have long, then what should I do and how can you help me? Never say, "Main kuch nahi kar sakta," because when you do that, you're saying, get lost. Because the one thing that you must promise is non-abandonment. Main hu na, aakhir tak. That's something that once you have learned communication skills, once you have learned how to manage symptoms, you will be able to confidently tell your patients that. Thank you. So for anybody who needs this presentation, I'm not sure how much has been recorded, but you're welcome to email me. And if I'm sure Kirti can help you with my contact details. Thank you so much.
Thank you, Dr. Gursani, for an enlightening lecture on end-of-life care, which actually went from legal perspective, like making a will, to brain death, do not resuscitate, terminal events, feeding, and all the problems.
Thank you.
Thank you very much. There are some questions regarding the first question is basically this is regarding one case that happened some time back. Sometimes patients are on life support system at home or otherwise on palliative care without life support system. They are not expected to survive for long period. But it happened once that such patient was there at home, and when patient died, the family physician gave the death certificate. But later on, it was discovered that son actually expedited the death by suffocating the patient. So any special guidelines for family physicians for giving DC in such patients?
So if you have been seeing the patient regularly, then I think this is just something that you have to be careful about suspecting. These are extremely unusual circumstances, and malified is malified. You rarely have any guarantee that you can get out of this. So you have to just be alert. But if you are following up the patient regularly And if you do not expect the patient to pass away so quickly, and if anything strikes you as odd, then I think you should be prepared to call it out.
So even sometimes if the patient, we know that he is terminally ill, he shows all the reports from the hospital documents and everything he shows. We know he is not expected to live, but the patient actually was not under your care, and suddenly they call the GP. He must be under your care maybe long time back, not very recently. So they should ask for a postmortem.
So now that is a little tricky. What you can do is, see, remember the death certificate is actually in two parts. One part is confirmation of death. So if you, it's up to you. I mean, you can confirm death, but to give a death certificate as the cause of death, if you have not seen the patient within the previous 15 days, I would recommend that you do not give the cause of death. You can confirm death, but do not give the cause of death. And that has to go back to whoever saw that patient last.
Okay. The second question is, do hospitals need any special permissions to provide palliative care treatments?
No. The only permission that is required is that they need to be registered to be able to dispense morphine. That's all. But the process has been significantly simplified recently. And one of the parts of it is that somebody within the hospital has to be trained in how to use morphine. So anybody who undergoes one of these palliative care courses will get certified for that.
Okay. Does old age homes need to have team of specialized physicians to provide palliative care treatment if any inmate requires it?
Now, geriatrics and palliative care and dementia care, all of these overlap. And if you look at palliative care, it is appropriate even for geriatric care. Ideally, all of this should be provided by the government or by NGOs. It should not be the burden of, say, the family alone or of that place alone. And if you look at Kerala, that's the one state where this has been managed best. I don't know. I mean, ideally, yes, what you're saying is the ideal situation. I'm not sure how, in a given place, how that can be managed. That is logistical difficulties that we will always have.
Can you just brief about the centers which are available currently in Mumbai, where end of life care team is available?
Okay, so
Like
end of
we
life
have
care,
in
there is
your
nothing.
hospital.
So you don't, end of life care, all of us are supposed to be able to give. It is, if you speak about palliative care, yes, palliative care units, there's one in Tata, obviously, then there is, Hinduja is the only general hospital which has it. Kokilaben has a part, Nanavati has a part. Then there are standalone units. There's one in Bandra called Romila Palliative Care. Then there is Pal Care. Then Prince Ali Khan also. So if any of you is interested, drop me a mail and I can connect you to the Mumbai Palliative Care Network. This is, well, all of us who are interested in palliative care, we meet regularly and we kind of coordinate activities amongst us. So if anybody wants to join and start moving in this direction, you're welcome.
One last question. For terminal dementia, Parkinson patients, relatives actually come to us to ask for certificate that they cannot decide, they cannot take firm decisions about the property matters and all. So for that, they need certificates. Where should we refer such patients to?
Okay, so if somebody is in the early stages of dementia, so if you're looking at a number such as the MMSE, if they are above the cutoff for dementia, then they are entitled to do whatever. If they are in mild to moderate dementia, then a neurologist or a psychiatrist, preferably somebody who's trained in cognitive neurology, can give such a certificate. Basically, this certificate has to be jointly given by a lawyer and a doctor. You ask the patient if he understands the will or the decision that he or she is taking, and confirm that they understand the consequences of what they are doing, and that they can explain to you. If they can, then actually they can sign away. But it is not, this is not a simple process. Once they go below this, say once they go into the stage of severe dementia, then there is no way that we can give any kind of certification. And in fact, it's advisable to ask them to go to court to get what is called guardianship. That's not, it's better for us not to get involved there. But again, I would suggest that for a family physician, if somebody has, even if somebody is very old, it may be better to ask for a neurologist's opinion before you certify them as fit to sign off on a will.
To sum up, palliative care requires multidisciplinary team to help terminally ill patients medically, emotionally, and spiritually. Everyone has the right their end of life to occur with dignity, respect, and free from pain. So the purpose of end of life care is to provide comfort and dignity. Thank you, Dr. Gursani, for joining us. Over to you, Ashwini, Dr. Ashwini. Thank you.
Thank you, sir, for such a wonderful and very informative session. It's really our privilege to have you as a speaker. Definitely the medical scenarios is changing. Previously, the GP could give the death certificates. Now it is better, all of us should be aware and have knowledge about end of care. Thanks, Dr. Kirti, for moderating the session.
Thank you.
Sir,
Thank you very
we would like to felicitate you. Please accept our felicitation and e-memento.
Thank you.
Thank you. Thanks a lot, sir.
Thank you so much.
Thank you. It was a really beautiful moderating the session. We would like to felicitate you.
Thanks.
We would like to felicitate Dr. Kirti Patil, and please accept our e-memento.
Thank you very much.
Thank you, sir.
Right. Bye.
Bye.
Okay. Again, I would like to remind our members, please log in with your names. If you cannot log in with your names, please put your name and registration number in question and answer section every hourly or so that we can keep track of people who have attended the academic session. If you have any doubts, please contact the registration team. And I would like to thank Sun Pharma for being associated with us as educational partner. So let's move on to the next topic. All of us know cases where a healthy person gets COVID-19 and dies suddenly of cardiac arrest. A nanovirus enters through our nose, resides in our lungs, and bites our hearts. So let us know what are the cardiac manifestations of COVID-19 from our expert, Dr. Atul Limaye. I request Dr. Archana Pate to moderate this session. I would like to thank Mulund Fortis for being associated as educational partner with us. Dr. Archana Pate does not need any introduction. She is the pride of Dombivli IMA. But it is my duty to introduce her. She is consultant physician and intensivist at Asta Hospital and RR COVID Hospital. She has been the chairperson, COVID Task Force IMA Dombivli, chairperson Scientific Committee, Indian Medical Association Chapter Dombivli, past president IMA Dombivli, executive member Maharashtra Medical Council, chairperson Mission Pink Health IMA Maharashtra State, past chairperson IMA Maharashtra State Women's Doctors Wing. She is recipient of multiple state and national awards. Ma'am, I request you to introduce our eminent speaker, Dr. Limaye.
Thank you, Dr. Ashwini, for that kind introduction. It gives me great pleasure to introduce a very gentle and humble human being, Dr. Atul Limaye. Can we have this slide, please? Dr. Limaye is working currently with Fortis Hospital, Mulund as an interventional cardiologist. He has previously worked as professor at the Icahn Hospital of Medicine at Mount Sinai and in cardiac cath lab faculty at the Mount Sinai Hospital, New York. He specializes in complex coronary and TAVI interventions with training at the highest volume lab in the US. His areas of interest have been interventional cardiology, clinical cardiology, coronary interventions, peripheral interventions, echocardiography, and nuclear cardiology. On behalf of IMA Dombivli, Dr. Limaye, we are really pleased to welcome you to this platform, and he would be now guiding us for the cardiac manifestations of COVID. Over to you, Dr. Limaye.
Sorry.
Good morning. Can you hear me?
Yes, you're very much audible, Dr. Limaye.
Dr. Pate, I can't hear you.
You are audible, Dr. Limaye. Am I audible to you?
Dr. Limaye, you are audible.
Dr. Limaye?
Sir, you are very audible, sir.
He is not.
Hello.
We are not audible to him actually. So.
Okay.
Sorry for the technical difficulties.
Maybe his laptop volume is low.
Okay, I can't hear you.
Sir, we can hear you now. Sir, we can hear you now.
Okay, so I can start?
Yes, sir. Please start, sir.
Okay. Okay. Thanks.
Yes, sir is starting with the session. He actually cannot hear us, but we are able to hear him. So I have asked him to start with the session, and if there is any glitch, we'll just get back to him. So you can start.
At the time of Q&A, we will.
Yes, we'll have to work out something. So you are audible. Dr. Limaye.
Give him a thumbs up maybe to go ahead.
Dr. Limaye, you are okay to go.
ये recognize नहीं कर रहा है.
हार्ड डिस्क है का?
Hello. Yeah. Okay, let me just attach my zip drive. Okay, I got it. I got disable केला होता है नहीं? Zip drive.
अच्छा हे एक्सटर्नल है ना विचारा लागेल कारण आयटीच आहे ना ते लोक
I'm just going to pull up my presentation. No, nothing like that. Okay, I just need some help with sharing my screen. Yes. Okay, 1 second. I'll just minimize my PowerPoint and go to that. Just please stay on with me 1 second.
Also ask him to, mute his telephone, the other telephone.
Sir, it is seen. You can, sir, please unmute yourself now. Your presentation is seen.
And you unmute yourself. Thank you.
Well, you can
Yes,
sit
sir,
right
your
there
presentation is
without a
seen.
mask. Good morning. Thank you very much for the opportunity to speak today. Small glitches, but hopefully all of you can hear me and see me. So the task in front of me today is cardiac manifestations of COVID-19. So what I let me see if my yeah. So there are 7 different types of human coronaviruses. The common cold is caused by 4 different coronaviruses. Those are listed there. These typically are not associated with any heart abnormalities. And then subsequently in the early 2000s, two new coronaviruses appeared with rare cardiac effects. Those were the MERS, which is the Middle East Respiratory Syndrome, caused by MERS coronavirus, and then the SARS-CoV coronavirus, which many of you have heard was there about 5 or 6 years ago. And then late December 2019 in Wuhan, the seventh coronavirus, the SARS-CoV-2, was identified, the so-called COVID-19, coronavirus disease of 2019, which all of us are now very, very familiar with. So what are some of the distinct features of SARS-CoV-2? First of all, there is cardiac involvement with COVID-19. It targets the angiotensin converting enzyme ACE2 receptor throughout the body, facilitating cell entry. And the heart is one of the many organs with high expression of ACE2. And the affinity of the SARS-CoV-2 to the ACE2 receptor is significantly greater than that of the old SARS virus, the CoV-1 virus. And therefore, we are seeing the damaging effects of COVID-19 on the heart. So how does it damage the heart? This is a nice illustration of how the COVID-19 damages the heart. First, by directly affecting the heart cardiomyocytes. You can see here the SARS-CoV-2 virus attaches itself to the ACE2 receptor directly and infects the cardiomyocytes, causing cardiomyocyte damage, necrosis, and cardiogenic shock. It can also affect the heart indirectly through release of various cytokines, chemokines, and lymphocytes, and it produces a systemic inflammatory response syndrome. And due to diminished blood supply, there is effect on the cardiac vasculature. So it affects the endothelial cells that line the coronaries and multiple vascular beds, causing heart attacks, arterial and venous thromboembolism. There is also dysregulation of the renin-angiotensin-aldosterone system that modulates blood pressure, and therefore you see fluctuating blood pressure, typically low blood pressure in patients who were previously hypertensive. This is a fairly common phenomenon that you will see in patients who return to you in your clinic post-COVID. So they were previously hypertensive, and now they barely need any BP medicines to control their blood pressure. So there is activation of a pro-inflammatory response, which involves platelets, neutrophils, macrophages, lymphocytes, with release of cytokines, and it produces a prothrombotic state, which we are all quite familiar with. Because of a prothrombotic state, there is a propensity for clotting, both in the microvasculature as well as in the large vessels. And this predictably leads to heart attacks and arterial and venous thromboembolism, as well as strokes in even young patients, which has been a manifestation of COVID-19. This is a nice diagram that essentially illustrates the inflammation and the complement activation done by COVID-19. So what you see here is a blood vessel with endothelial cells, the intima, which is single cells here. And then as you have neutrophils and macrophages that infiltrate that area, with underlying vascular damage because of direct toxicity of the COVID-19, you immediately start the process of platelet activation and aggregation with release of tissue factor and coagulation factors. And then just as the nidus of a heart attack is a vulnerable plaque that ruptures, similarly, the vascular damage caused by COVID-19 initiates this entire cascade phenomenon, which leads to vascular damage, platelet aggregation, activation, and subsequently can cause a heart attack in the macrovasculature. This is a cartoon that illustrates what happens at the lung level. So essentially the same thing. This is your lung, the alveolus, and the SARS-CoV-2 virus releases all kinds of cytokines, macrophages, neutrophils, and then there is a dysregulated inflammatory response and a cytokine storm. And that cytokine storm in the severe state can lead to multi-organ dysfunction. The most common organs obviously are the lungs, so it remains primarily a respiratory illness. But you can also have effects on the heart. We talked about heart attacks. It causes profound coagulopathy and therefore can lead to DVT, thromboembolism, or even arterial thromboembolism. Can affect the liver, it can affect the gut and the musculature. And then sometimes the brain as well, leading to microvascular strokes. Now, restricting my discussion to the heart, this is the spectrum of all the echo abnormalities in patients who have biomarker evidence of myocardial injury and COVID-19. So all sorts of things can be seen on the echo. So you can have LV wall motion abnormalities, you can have RV dysfunction, you can have global left ventricular dysfunction, isolated diastolic dysfunction, pericardial effusion, or a combination of all of these, which is the intersection of this Venn diagram right in front of you. So there is a diverse spectrum of the damage that COVID-19 can cause to the heart. So there can be limited necrosis of heart cells causing injury with mild troponin leak. And actually this is evidenced in about 20% of all hospitalized patients and about more than 50% of those with pre-existing heart conditions. You can have myocarditis. There can also be cardiogenic shock when these processes become quite profound. Let me illustrate a case that I saw about a month and a half back in our emergency room. So a 28-year-old young male, no hypertension, no diabetes, no risk factors, who was admitted with marked dyspnea, cough, and fever, the classic hallmarks of severe COVID-19. He was seen in the emergency room in profound respiratory distress. A chest X-ray and a CT scan showed classic COVID with extensive bilateral ground glass opacities in both lung fields. We did a quick echo screen which showed severe LV dysfunction with an EF of about 20 to 25%. He had borderline blood pressure of 90 systolic. An ECG showed sinus tachycardia, but no other ischemic changes were seen on the ECG. So we took him emergently to the cath lab, inserted a balloon pump, knowing that he was progressing towards cardiogenic shock in addition to respiratory failure. And then just with a balloon pump insertion, he was sent to the COVID ICU. His subsequent lab parameters are shown. So his high sensitivity troponin was elevated at 211. The normal upper limit in our lab is about 15 to 20. So this is almost 10 times elevation of high sensitivity troponin. He was in renal failure. His creatinine was 2.2. He had a profound neutrophilic leukocytosis with a white cell count of 42,000. Hemoglobin was 13. And all the pro-inflammatory markers of COVID-19 that we are all familiar with were predictably raised. So CRP was 200, D-dimer was, except the D-dimer, I must say, the D-dimer was only 0.4, which is within normal limits. His ferritin was 200, his LDH was 550, and interleukin 6 was 194. So you can see profound cytokine storm, you can see renal failure, you can see cardiogenic shock with BP of 90 systolic requiring NORAD, adrenaline, and intra-aortic balloon pump. And you also see respiratory failure requiring intubation. So intubated in the COVID ICU, he was given all supportive therapies, steroids, intravenous antibiotics, remdesivir, and he had remarkable improvement in all of his parameters. He was extubated on day 3 to 4, and he went home by day 10. And a repeat echocardiogram 3 weeks after the first one was normal. So this is a gratifying response that we see in young patients with COVID-19. So they come in multi-system failure, cardiogenic shock, respiratory failure, acute renal failure. And then primarily, I think because they are young, they are able to be salvaged and salvaged very, very quickly and turned around to return to a fairly normal activity level in 3 to 4 weeks' time. So what this gentleman had, I think, was myocarditis. He presented, myocarditis patients can present with chest pain, exercise intolerance. They can also present with VTVF or other ventricular arrhythmias. They typically will have troponin elevation. They can have focal or globular ventricular systolic function impairment. They can also have heart block, out of hospital cardiac arrest, or sudden cardiac death. We have considered cardiac MRI for definitive diagnosis of myocarditis. Myocarditis is a risk factor for in-hospital mortality. The troponin concentration correlates with the risk of mortality and worsening disease. What are some other cardiac manifestations of COVID-19? They can have stress cardiomyopathy, the Takasubo syndrome. They can have ischemia from endothelitis and the typical plaque rupture with thrombosis, which is indistinguishable from the run-of-the-mill myocardial infarction that also presents with plaque rupture and thrombosis. And lastly, they can also have multisystemic inflammatory syndrome of children, the MISC. Thankfully, the MISC entity is extremely rare, both in Western countries as well as in our country. So MISC is thought to be immune mediated. There's a wide spectrum of the illness encompassing all the multiple organs and systems in our body. They can also have vasculitis, coronary artery aneurysms, and they can also sometimes present in cardiogenic shock. COVID can also coexist with left ventricular failure. And this, I put this especially because this was a learning for me. And so I wanted to present a case that illustrates this learning. And we have seen several cases exactly like this case. So I thought I will use this case to illustrate that problem. So a 50-year-old lady who was admitted with a large anterior wall myocardial infarction. So we did a primary angioplasty to the LAD. And typically with late presenters with large MI, they, at least in the initial period, tend to have severe LV dysfunction. So this lady, when we did the echo, her LV was 15 to 20%. Her initial COVID RT-PCR came out negative. So she was diuresed aggressively. We limited her fluid intake to about 1200 ml per day. And she was negative by almost 700 to 800 ml every single day. So we diuresed her very aggressively, Lasix 3 times a day, aldactone, all the usual heart failure medicines. Despite doing all of that, she continued to have dyspnea. Now this is very unusual. You know, all of us treat left ventricular failure, every other day, if not every day. And if you are successful in diuresing a patient and making them negative every single day, and their creatinine stays reasonably stable, in other words, they don't develop progressive renal failure, then they should get better. That's generally how left ventricular failure behaves. They may not get better in 2 days or 3 days, but that by day 4 or day 5, they are pretty much off of oxygen. They don't require oxygen support, and they are ambulating and getting ready for discharge. Now look at what happened to Our Lady. Despite being negative by almost 800 ml every single day, on day 5, she continued to have dyspnea. Retested for COVID, and now she's COVID positive. So the reason for her dyspnea was not just left ventricular failure, it was concomitant COVID. So the lesson for me is if someone comes in, they are tested COVID negative, we should not just assume that they are COVID negative, even if they clinically are progressively worsening. That I think is the lesson of this. Because as all of you know, the sensitivity of RT-PCR is only about 70% or so to pick up COVID-19. The sensitivity of the rapid antigen test is even lower, probably 40 to 50%. So if you have a COVID RT-PCR which is negative and your patient is not doing well, continuing to be dyspneic, then we need to rethink and retest, have a low threshold for retesting the COVID RT-PCR. And you would be surprised when the COVID RT-PCR can turn positive. So then she was given appropriate, COVID therapy in addition to her heart failure therapy. And so now we knew that we shouldn't continue to aggressively diurese her to the point of renal failure, maybe stop, add steroids, add the other agents, and then treat her for COVID in addition to her left ventricular failure. Some special situations that some of us may face, and what advice can we give to young people who are present with either just COVID-19 with cardiac failure or COVID-19 with myocarditis. And these guidelines are taken from the athletes who present with COVID-related myocarditis, but I think we can use the same guidelines to advise our non-athletic but nevertheless active young patients who ask you what to do in terms of their activity levels after they've had COVID-related illnesses, COVID-related cardiac illnesses, I must emphasize, not COVID-related respiratory illnesses. So if they've had acute myocarditis with any of the following criteria, either the clinical syndrome, which includes heart failure, angina, or known myopericarditis, or they have unexplained increase in troponin, ischemic ECG changes, arrhythmias, AV blocks, regional wall motion abnormalities, or pericardial effusion, and or if their cardiac MR is suggestive of myocarditis, then I think before returning to active sports, all athletes who have been diagnosed with myocarditis should at the very least undergo an echocardiogram, a Holter, and a treadmill test no less than 3 to 6 months after their illness. And if all of these three things are normal, then you can advise athletic activity. So I'm talking these recommendations again are for cardiac COVID-19 patients. And those patients who want to engage in high intensity sports. These recommendations are not for your usual COVID-19 patients who want to go for a walk in the park, or you want to go shopping or driving, etc. These are patients who are interested in doing high intensity sports. So people who want to run a half marathon or a full marathon, or they are part of a national or a state level cricket team or hockey team, things like that. So I think this is a good indicator of what we should do with those types of patients. They should have an echo, a Holter, and a TMT. And if all these things are normal, then they can safely return to high intensity sports activities. So same thing, they can resume training or competition if they have a normal LV function on the echo, if all their inflammatory markers, troponin, BNP, CRP, all of them have become normal, and if they no longer have any arrhythmias on Holter monitor, and if they have a normal treadmill test. Just one slide on something called long COVID. You may see some patients in your clinic with this. So the patients have had a COVID illness, whether it is mild, moderate, or severe. They have recovered from all the manifestations of COVID illness, and yet they continue to have some amount of fatigue, dyspnea. Some people may also have chest pain. They can also have palpitations, arrhythmias, and fluctuating blood pressures. Now, this is becoming an increasingly recognized entity, and there have been various names attributed to this. One of the names is long COVID, which is patients with COVID who continue to have some symptoms even after all their COVID illness has resolved. I think what they primarily need is some reassurance that this is a known entity, that they are not alone in experiencing all of this, that these symptoms will eventually subside. Some people may take a little longer, whether it is 3 to 4 months post their COVID illness. What are the challenges with COVID-19 and heart disease? Well, the first challenge is the marked heterogeneity. So all of us have seen this. You have patients who are completely asymptomatic with COVID-19, and then there are patients who have mild, moderate, or severe or fatal COVID-19. and there is not a single criteria that can help predict who will have an asymptomatic illness and who will have a severe or a fatal illness. And that, I think, is the challenge in terms of how to prevent or how to take care of COVID-19 in our population that we are facing. What has been my experience with COVID-19 as it pertains to its cardiac manifestations? Well, the Fortis experience, it has predominantly been a respiratory illness. So as the word itself suggests, it's a severe acute respiratory syndrome. And so we have predominantly seen respiratory compromise ranging from mild, moderate, severe to intubation. When it comes to cardiac manifestations, acute coronary syndrome, NSTEMI and STEMI has been common. Now, whether the NSTEMI and STEMI happened because of COVID-19 or it was going to happen anyway, that is very difficult to say for me. But this is the most common COVID manifestation is ACS, NSTEMI and STEMI. We have seen several cases of stroke, particularly in young individuals with COVID-19, as well as in old individuals with the traditional risk factors for stroke. We have seen arterial thromboembolism. So patient went home, completely recovered from COVID-19, returned 4 weeks later with a cold foot. And the etiology of the cold foot was a thrombus in the popliteal artery and was attributed to COVID-19 because that person or those people did not have any other risk factors for arterial thromboembolism. For example, cigarette smoking, atrial fibrillation, bad vasculopaths. So they did not have any of those things. Venous thromboembolism, common, DVT, as well as pulmonary embolism. Isolated heart failure because of COVID is rare. We have seen maybe 1 or 2 cases. Thankfully, myocarditis, the first case that I illustrated of the 28-year-old boy, 28-year-old man, has been extremely rare. I mean, I can think of maybe just 1 or 2 cases of proven myocarditis with COVID. This is in stark contrast to the experience of Europe and the experience in the US, where they have seen considerable extent of myocarditis in their patient population with COVID-19. So the Italian experience has been 20 to 30% of COVID-19 with myocarditis. Thankfully, our experience has been the opposite. I can tell you that, and I've been at this since the beginning of the epidemic, our experience with myocarditis is that it is extremely rare in our population. So what distinguishes the propensity for older people to have severe COVID versus younger people to have not so severe COVID? I think it boils down to the fact of depleted defenses. So the immune system gets less efficient with age for a variety of reasons. And one of the reasons is that the T cell or the B cell response is blunted as people get older. So when you're younger, you have plentiful T cells which produce a diverse set of memory T cells that can fight all the pathogens. Our B cells that make antibodies that can stop the virus from infecting cells are also made in abundance when people are younger. The immune response that ramps up inflammation to help respond to all of these threats is also much more robust when patients have a younger immune system as compared to an older immune system. And therefore, with the age, the number and diversity of the T cells declines, the functionality of the B cells also declines, and therefore older people tend to have much more severe COVID than younger people. I just wanted to touch on some things that may be of interest to the people, to this viewership. And many of you may be quite familiar with this chart, but I like these things because it's not just your patients, sometimes it's your relatives and your family friends who want some information on testing of COVID. So I find this very, very useful. This is just a revision for many of you. So in the pre-symptomatic phase, 0 to -7, the positivity rate of RT-PCR is quite impaired. The accuracy, the sensitivity of RT-PCR really picks up when a patient becomes symptomatic. So when a patient has fever or sore throat, loss of taste, loss of smell, myalgia, fatigue, all those symptoms, once he gets symptomatic, and if you do a COVID RT-PCR within the next 3, 4, 5, 6 days of symptoms, then your positivity rate is really high. If you do the test too soon, so a lot of people are very nervous out there. So they go to a shop or they go to a friend's place and that friend turns positive and they panic and they call you and say, what should I do? And even without waiting for you, they go and have an RT-PCR test. And if they are in that pre-symptomatic phase, their RT-PCR may be a false negative. So I have started telling people who call me, I'm a cardiologist, so I don't deal with this thing on a routine basis, but my friends will call me, my relatives will call me. And what I say to them is, don't get RT-PCR tested unnecessarily. If you have symptoms, then the chances that your RT-PCR is accurate go very, very high. So test when you have symptoms. If you test before you have symptoms, you can test, but just remember that the negative test that you get may be a false negative. You can test all you want. You just need 1800 rupees and a lab to test. But just remember that if you are negative in the pre-symptomatic phase, that test may be false negative. So this is just a cartoon about that. And then as you can see, this green line and the blue line is the antibody response to COVID-19. So what you can see is by about week 2 of symptoms, you start to get an antibody response, both IgG and IgM, and that antibody response persists through week 3, through week 4, and who knows how long, because we don't know how long our antibody immunity is going to persist for. But we know at least for several weeks after recovery from COVID-19, you will have a robust IgG and a robust IgM response to the COVID-19. The IgM, which is the acute phase antibody, will decline after several weeks. And then hopefully, if we are lucky, the IgG antibody will persist, giving us long-lasting immunity. What are some prevention strategies? Again, I'm deviating from my original protocol, but just in the last several minutes, social distancing, mask wearing, washing hands, rapid testing. All of us know very well about this. The only thing to remember is that it's a Swiss cheese model. So no one thing is protective. If you don't do any of these things, the holes in the Swiss cheese will line up and the coronavirus on the left will travel through all of these holes that you are allowing and infect you. But if you do all of these 4 things, chances are that you will protect yourself from contracting COVID-19. What about the treatments? I'll go very rapidly. I've been following randomized controlled trials of COVID-19 therapy for a long, long time. And you will be astonished to know, as I am, that to date, there is only one drug which has been shown in randomized controlled trials to have any effect on overall mortality, and that drug is intravenous dexamethasone. There is no other drug, and I'll show you randomized controlled trial slides to prove that. The Solidarity trial, a trial run by the WHO, published its interim results on 15th October 2020, about 2 weeks back. And all 4 treatments, the popular treatments, were evaluated: remdesivir, hydroxychloroquine, lopinavir, and ritonavir. No effect on overall mortality, no effect on initiation of ventilation or duration of hospital stay in hospitalized patients. Now, just remember, all of these agents are not coronavirus agents. Remdesivir is an original hepatitis C agent. These are all redeveloped drugs, repurposed drugs. Hydroxychloroquine is a malaria drug. Lopinavir, ritonavir are HIV drugs. This is the graph from that trial. You can see, I don't need to convince you, remdesivir, hydroxychloroquine, lopinavir, interferon, no effect on mortality whatsoever in a randomized control trial. Similarly, favipiravir, which is a repurposed drug for influenza, convalescent plasma, azithromycin, tocilizumab, which is originally a rheumatoid arthritis drug, hydrocortisone, all of these agents have had no effect on mortality in randomized controlled trials. In fact, the hydrocortisone study was stopped prematurely because there was no benefit, the REMAP CAP trial. So I said this before, the recovery trial was the Oxford trial with intravenous dexamethasone, which showed mortality benefit as well as benefit free of ventilation at 28 days. So dexamethasone reduced deaths by 35% in ventilated patients and by 20% in other patients receiving oxygen therapy. The last line on this slide is very, very important. There was no benefit among those patients who did not require respiratory support. So all your patients who have either mild illness or even moderate illness, who do not have respiratory compromise, they do not require oxygen. If you have a patient who does not require oxygen, he does not require IV dexamethasone. As simple as that. In fact, you may do some harm by giving dexamethasone early or inappropriately, according to the recovery trial. There are some controversial strategies that are being undertaken, and I thought I would just highlight a couple of them. I shouldn't call them controversial, I should call them strategies without proven randomized control trials. One of them is the use of anticoagulation post-COVID. So there is an ongoing trial which is called the COVID Prevent trial, which is using rivaroxaban, the Xarelto, 20 milligram for 7 days or duration of hospital stay, and then subsequently 10 milligram for 28 days or longer. That trial is ongoing. We do not have results of that trial yet. Despite that, what us and many other hospitals are doing is putting patients on an anticoagulant when they go home, particularly if their D-dimer is high. So we feel that if their D-dimer is high, they are in a higher prothrombotic state, and therefore we ought to give them a protective agent for 28 days, 30 days, whatever the case may be, until their D-dimer comes normal, at which point you can discontinue that anticoagulant. Now just remember, just because we are doing it doesn't mean it's right or it's proven. It just means that there is no randomized controlled trial to prove that strategy. Another strategy is the COVID HEP trial, HEP, which is looking at the therapeutic versus prophylactic doses of low molecular weight heparin. So as you know, in most hospitalized patients in Mumbai and other places, we are putting them on low molecular weight heparin. I'm talking about hospitalized COVID patients or ICU COVID patients. Now you can make a case for prophylactic doses of LMWH, patients who are non-ambulatory, who are bedbound in the ICU, etc. You can make a case for prophylactic doses. And that COVID HEP trial is ongoing in a randomized fashion that will inform our decision to whether to continue this strategy or not in terms of the low molecular weight heparin. This is my last slide, and I think I'm almost near my time slot, which is all the vaccines that are in development. The University of Oxford vaccine is in phase 3, so are many, many Chinese vaccines. In fact, the Chinese army has begun giving its recruits the Chinese coronavirus vaccine and Johnson & Johnson vaccine is in phase 3. So most people accept some of these vaccines to come through either in the first quarter of 2022 or definitely by the second quarter of 2022. So until then, I think what we have to do is continue with all the preventive strategies of COVID-19, watch out for cardiac involvement with all the things that I described, look for cardiac symptoms and treat the cardiac symptoms, have a heightened awareness of ACS and STEMI in patients who are complaining of chest pain or who have a chest syndrome secondary to COVID-19. I think I'll stop there and I'm open to questions. Thank you very much for the invitation. Again, I hope this talk was somewhat comprehensive. I went somewhat beyond what was asked of me and touched upon a little bit of the preventive strategies as well as the therapeutics of COVID-19. Thank you very much.
Thank you, Dr. Limaye. It was indeed extremely comprehensive and very lucid. And I think our delegates have got a good idea about, in what way COVID can involve the heart. I would like to take up a few questions. I think by now we all know that, generally it is known that COVID goes through these three phases, the immunological phase, the pulmonary phase, and the inflammatory phase. So what I would like to know, generally, where do we see, the heart involvement most commonly? Do we see it initially at the immunological phase, or do we see it later in the illness? I'm not talking about the inflammatory or rather the prothrombotic phase. I'm not asking about that. I'm talking more so in terms of myocarditis.
Ma'am, are you sure he can listen to us? Maybe you will have to call him and ask the question on phone.
I'll ask Dr. Limaye, Dr. Himmat. Can you put me on line with Dr. Limaye? I just talked to him on phone. The viewers, please excuse me. I'll be talking to Dr. Limaye on phone and then he can answer us through the Zoom. Just give me 1 minute. We'll connect with him.
Yes, sir.
Yeah, I'll be asking you some questions on phone because I don't think you can hear us, but we can hear you very well. So, So what I wanted to ask, sir, was that, we generally know that COVID passes through these three phases, the immunological, the pulmonary and the inflammatory phase, inflammatory phase. So at what phase do we generally expect the heart to be involved? We are not talking about the thrombotic, elevation of the coagulation factors and all. But when we talk in terms of myocarditis and so when do we expect the heart involvement to be? Generally in the course of illness.
So there's a very interesting question about when should we expect the cardiovascular involvement of COVID-19, whether it is in the early phase, the inflammatory phase, the cytokine phase. And our experience has been that it typically happens early on. So patients present with ACS and STEMI early on in their illness. It is very, I don't think I've seen a single case where somebody was in cytokine storm in the ICU and they call us because they're having a STEMI or an NSTEMI. So I think it's early on in the illness that we are seeing ACS and STEMI. The prothrombotic state and the thromboembolism can happen anytime. So the venous thromboembolism, DVT, pulmonary embolism, we have seen it happen 4 to 5 to 6 weeks after the COVID illness. So there is no time point. I don't think we can pinpoint that it happens in the inflammatory phase. So I want to be careful how I answer.
Sir, you are not audible. I think your internet connection is slightly unstable. Is he audible to others?
Yes, he's audible.
Hello?
Yeah.
Yeah, just 1 second. So what I wanted to know was what is your personal experience with remdesivir? So now you're audible.
So I want to be careful how I answer this question. So see, remdesivir is predominantly...
My question here is use of remdesivir in myocarditis or, any such patients where you would see, because otherwise, so what has been your personal experience when we talk about heart involvement, in COVID patients? the cardiac manifestations.
So if our patients who have ACS and STEMI,
yes,
we treat them with standard cardiac medications.
Okay. And yeah. So the treatment would be as good as you would treat any cardiac patient presenting with these symptoms.
Absolutely.
Okay. So there would be per se, there would be no antivirals or anything which you would be so inclined to be giving to these patients.
Exactly. The one difference that I will emphasize is that we would like to use our most potent antithrombotic agents. So for example, we would like to use Brilinta or Prazodoc instead of clopidogrel. Because as you know, these are stronger antithrombotic agents as compared to clopidogrel. So that is the only slight difference that I would make in terms of therapeutics.
Right, sir. And post-discharge, then these patients, like, would you be recommending, like you have just said, the use of oral anticoagulant agents? So, in case these patients present with, any thrombotic events, so would you be giving them antiplatelets as well as oral anticoagulant agents?
So yes, so there are two parts to this. One is, would I give them prophylactic agents or not? The answer is no.
Okay.
Because they are already on two antithrombotic agents. Right. If they develop another thrombotic event, whether it is a DVT or a pulmonary embolism or an arterial thrombus, now we are forced to give them an anticoagulant in addition to an antithrombotic agent, in which case I will drop the aspirin and I will give them one antithrombotic, your choice, Prazodoc, Brilinta, or clopidogrel, and one anticoagulant, your choice, Eliquis or dabigatran or Xarelto. So it will be a dual therapy, not a triple therapy. I will drop the aspirin. The reason
there is,
I drop the aspirin is because I think 3 drugs will become too much.
Too much. Sir, and there is a general, I don't know, but what I have observed in my practice when other patients come to me with prescriptions from other places where they have been treated, there is like generally there's a fashion on discharge giving ecosprin. Like to all patients of COVID who get discharged from hospital. So how would you place the use of ecosprin in the COVID patients who go home, and the use of ecosprin for a few months?
So that's an excellent question, and there are two ways to look at that question. One way is the, extremely scientific way, which is to say, can you show me a randomized controlled trial that shows benefit of aspirin in COVID-19 patients? And if you ask me a question like that, the answer is no. There is not a single randomized controlled trial that shows benefit of aspirin with COVID-19. The trial is ongoing with COVID and cardiac patients right now, but it is in phase 3. We don't know the answer to that. What is a more practical solution? We all know COVID is a prothrombotic state. And, aspirin seems to be a very innocuous and a risk-free solution to that problem. So if I have a patient who is otherwise healthy, no risk of GI bleeding, no risk of hemorrhage, no other problems that I can anticipate with a low dose ecosprin, why not? I would give him the ecosprin for 28 days or 6 weeks. If I have an elderly patient, 70, 75 plus, who has had GI bleeds before, has had problems with ulcers before, I would be very careful giving that person random person ecosprin. So it would be a case by case selection basis. If I am not paying a price for giving ecosprin, I would give ecosprin. If I think I will end up paying a bleeding price for ecosprin, I will not give ecosprin.
Thank you, Dr. Lima. Thank you for that excellent presentation. And I think many of our viewers have enjoyed. And
thank you, Dr. Lima. Thank you for that excellent presentation. And I think many of our viewers, we are running short. So thank you once. Subsequent proceedings to Dr. Ashwini. Thank you so much, Dr. Lima.
I agree with Dr. Archana.
Thank you, sir, for an amazing lecture. Thank you, Dr. Archana, for moderating the session. Now we would like to felicitate Dr. Limaye. Please present e-memento to Dr. Limaye, sir. Now I request to felicitate our moderator and present e-memento to Dr. Archana. I thank Mulund Fortis for being educational partner with us. We move on to the last session of the morning. You all must have heard Amitabh Bachchan's recitation of poem on COVID-19, Guzar Jayega, Guzar Jayega. He recites, खौफ बरपा है, हर तरफ लोग हैरान हैं, ये वो कहर है जो दुनिया को डराने आया, ये वो कहर है जो दुनिया को डराने आया, मगर ना समझ है जो इंसान को हराने आया. Thousands and thousands lives were lost until we could figure out the pathophysiology of COVID-19. But it was just a matter of few weeks that we cracked the code. There was a gross change in managing critical cases with ventilators to managing with anti-inflammatory and anticoagulants. It worked wonders. It saved lives. Our next topic of presentation is bleeding profile, a game changer in COVID. I thank Mulund Fortis for being educational partner with us for this session. Moderate this session. Dr. Meena, she doesn't require any introduction, always smiling, charming, and always ready to help. She's consultant physician practicing cardiology at Lifeline Hospital, Dombivli West. She has been the immediate past president of IMA Dombivli. She has been the chairperson of IMA Dombivli Hospital Board of India. She has been the IMA Maharashtra State Mission Pink Health Journal Coordinator. I invite Dr. Meena to introduce our speaker. Dr.
Thank you, Dr. Ashwini. Thank you very much for the kind introduction. Dear friends, our pre-lunch session today, we have with us Dr. Shubha Prakash Sanyal. He will be speaking on bleeding profile, a game changer in COVID. Dr. Sanyal is an eminent hemato-oncologist and a bone marrow transplant physician at Fortis Hospital, Mulund. He has more than 45 transplant cases to his credit, and with over 10 years of experience in management of hematological malignancies. His special interest lies in the management of thalassemia and sickle cell anemia, including prenatal diagnosis and genetic counseling. He has to his credits international fellowship training in bone marrow transplant program at Vancouver. Over to you, Dr. Sanyal, for your kind presentation. Please welcome Dr. Sanyal.
Thank you. I'm scared.
Sir, we can't hear you. Sir?
Yeah, can you hear me now?
Yes, sir.
Just give me a minute. I just clear my screen. Yeah, can you see the slides?
Yes, sir, we can see the slides.
And I'm audible, right?
Yes, sir, absolutely.
So thank you, Dombivli IMA, for giving me this lovely opportunity. Good afternoon to all. When this topic is given to me, and I start reading, there are a lot of data is compiling and a lot of contradictory data is also arising. So I tried to do as much as possible, very comprehensive with our old knowledge of thrombosis and bleeding and interpretation of the investigations, how we're supposed to do in the bedside and go way forward. So whenever we talk about the bleeding profile or thrombotic profile, I always explain the word It is a seesaw in a park where the children are playing, and one way is the thrombosis and other way is the bleeding. And any thrombotic or bleeding issues can be very nicely explained by our old thought of the Virchow's triad that everyone we know, we learned in our MBBS days. So Virchow's triad is basically 3 points: endothelial injury, stasis or the slowing of the blood flow, and the third point is the hypercoagulable state. Dr. Limaye very nicely explained about the virus. So I'm not going details about the virus and the histories of the virus. So basically, coronavirus, the COVID-19 we know, it directly invasion of the endothelial cells. Endothelial cells are the first lining cells of the blood vessels, both artery and the vein. So it causes endothelial injury. It causes microvascular inflammation. It causes endothelial exocytosis, and most importantly, endothelitis. There is a very new terminology which comes from this COVID era, what is called neutrophil extracellular trap. What is that? It is basically a form of decondensed chromatin dead neutrophils, and it's promoting prothrombotic state. So you may heard many times that patient actually went home and everything is fine, and then back with a DVT or a PE. So probably the neutrophil extracellular trap is very important from the pathophysiology of this particular group of patient. Complement-mediated endothelial injury is also known, caused by the SARS-CoV-2 spike protein. Stasis is a part of the acutely ill patients. They are immobilized. So you can expect stasis, particularly the ICU patients. And the third, what are the hypercoagulable state you can see here? So here, factor 8 goes up. Fibrinogen level goes up. There are a lot of circulating prothrombotic microparticles. NETs I already explained, and the hyperviscosity. So these 5 points make your blood more thicker. So in endothelial injury, stasis, and hypercoagulable state, all three makes the Virchow's triad, is actually the cornerstone of any thrombotic bleeding balance in our system. I am very grateful to the investigation of the D dimer. You know why? Because in hematology world was very much popular when dengue came in a light, and platelet and dengue make us really favorite for the physicians and entire population, that there is a subject called hematology and platelet is part of hematology. So I always very jokingly and very fondly call platelet is our greatest PRO in marketing hematology. Same way, I'm very grateful to the test called D dimer. D dimer is also helping us to understand a lot of things, lot of new things. So let me first tell you what is D dimer mean. So D dimer is basically, it is a degradation product of the cross-linked fibrin. So when there is a bleeding and ultimately there is a clot formation, this clot are actually stabilized by the cross-linked fibrin, which is done by factor 13. And when this cross-linked fibrin degraded, they form the D dimer. So it means, D dimer means it indicating augmented thrombin, and this fibrin mesh actually resolved by the plasmin. So anti-fibrinolytic activity. Very elevated level of D dimer have been observed that correlate with disease very poorly. But remember one thing, high D dimer level are common in any infection, any inflammation, bleeding, pregnancy, any acutely ill individual. My ID physician few days back asked me a beautiful question. There is a patient came with a fever, suspected COVID, but ultimately turned out to be dengue. And he did D dimer as a package of the COVID protocol. and the D-dimer is quite high. And he asked me a simple question, what does D-dimer mean to this dengue patient? So remember, there are thousands causes where D-dimer level can goes up. But most important, it has a very strong negative predictive value in thrombosis. Means what? Suppose your D-dimer level is normal or low, that means your body is not thrombogenic. So what is the status of D-dimer before COVID era? So as a hematologist, whenever we suspect that there is a thrombosis, we do straight away imaging. If there is a DVT you are suspecting, you are doing colored Doppler straight away to look for there is a clot there or not. If you are suspecting pulmonary embolism, you do CTPA straight away. If you are suspecting cortical venous sinus thrombosis, you are doing straight away MR venography. That is the way science was practiced. But when we hematologists stop the anticoagulation after the designated time, that point of time we obviously we repeat the imaging, but I always do in my practice D-dimer, and D-dimer is normal, your imaging is satisfactory, enough collateral formation, enough recanalization, we know that it has taken care of nicely and there is no thrombophilia. That is a proper time to stop anticoagulation. So that was the role of the D-dimer practice before COVID era. But in COVID times, we do D-dimer and we know it is related with the severity of the disease. So what is the basic coagulation abnormality you are seeing among the three? Predominantly coagulation abnormality is basically a hypercoagulable state. And there are two terminology I'll just describe you. One is called thromboinflammation. It's a new terminology. So it means there is inflammation, there is endothelitis due to the microvascular inflammation and direct invasion of the virus, and what causing the thromboinflammation and ultimately the clot formation. There is another terminology I describe in detail, what is called COVID-19 associated coagulopathy, CAC. And it is different from the DIC. And another thing which is extremely important, shutdown of fibrinolysis. What does it mean? Whenever there is a small clot, body wants to dissolve this clot by the plasmin. But here, the fibrinolysis never happened. Fibrinolysis is stopped, so clot persists. So thromboinflammation and the shutdown of the fibrinolysis, two very new concepts we as a hematologist we are learning in the COVID era. And ultimately the COVID-19 associated coagulopathy. So what is COVID associated coagulopathy? Here, so one more thing, very basics. Whenever we talk about the coagulation test, 4 tests, platelet count, PT, activated partial thromboplastin time, and the fibrinogen. D-dimer is actually never comes in the category of the coagulation test, basic coagulation test. So platelet count is in CSC, either normal or increased. PTA, PTT, either normal or slightly prolonged. Fibrinogen is increased as a part of the acute phase reactant. So if fibrinogen level goes up, D-dimer is again goes up. Factor 8 is also acute phase reactant, it goes up. Von Willebrand factor antigen highly increased because von Willebrand factor is staying inside the endothelial cells of the blood vessel. And here is the endothelial injury happens due to microvascular inflammation or due to the direct invasion of the virus. And most important, what we see in the pregnancy, there is a minor changes in the natural anticoagulant. So protein C, protein S, antithrombin 3 levels are mildly reduced. So body moves towards a more thrombotic state or prothrombotic state. So this entity is called CAC. There can be transient APLA antibody positivity. Remember one thing, in each talk I tell very clearly, APLA antibody does not mean antiphospholipid antibody. Remember, antiphospholipid antibody means lupus anticoagulant, anticardiolipid antibody, and beta-2 glycoprotein antibody. So they are a little transient APLA antibody positive, but these are not APLA syndrome because this happens due to infection related positivity, transient, and they go away after some time. So this is called CAC and it is different from the standard DIC. So typically bleeding predominates in acute decompensated DIC, we all know. Thrombosis predominates in chronic compensated DIC. So there is a misconception between many people that DIC meaning is only bleeding. No. So again, think about the seesaw, bleeding and thrombosis, just like a tipping the balance in different way. So hypercoagulable state in patients with the COVID-19 is more similar to compensated DIC than to acute decompensated DIC. What is the differentiating point between DIC? Platelet count and APTT are mostly typically normal in COVID-19 associated coagulation parameters. I think I'm very clear about few basic stuff, which is extremely important to understand the thrombosis bleeding profile in COVID-19. So come to the very basic thing, thromboembolic manifestations. So venous thromboembolism, including DVT-P, seen around 20 to 25-30% cases in ICU, even when the prophylactic anticoagulation is used. So older age, male sex, Hispanic ethnicity, coronary artery disease, prior AMI, and higher D-dimer more than 500 at hospital presentations are the risk factors for the thromboembolic manifestations, particularly the venous side. Interesting points. Coronary artery disease is an arterial disease. AMI is an arterial involvement, but these two also proven significant risk factor for the history of these two are the presentation of the thromboembolic manifestations of the DVT and P. So which is an interesting finding. D-dimer level was never studied in any thrombosis about the risk factor, but we now know the higher D-dimer values are at hospital presentation are at the important risk factor. Arterial events, arterial thrombosis, obviously less compared to the venous events, happens including the central nervous system. Largest study containing 3,334 individuals reported stroke in 1.6% of the patient and AMI around 8 to 9% of the patient. Here, again, the older age, male, Hispanic, coronary artery disease, and D-dimer more than 230. In venous, it is more than 500. It is here more than 230 is actually correlated with the events. Arterial events are associated with increased morbidity and mortality. And what Dr. Lima explained, limb ischemia. Patient went home, come back with a popliteal artery clot. Microvascular thrombosis that we are seeing in this particular group of disease. So whenever we hematologists, we talk about what are the investigations we do, we always follow International Society of Thrombosis and Hemostasis, what is called ISTH guideline. So routine testing for all inpatients, so patients who are admitted in the hospital, CBC, PT-APTT, fibrinogen and D-dimer at best level. For outpatient, asymptomatic outpatient, routine coagulation testing is not required. But remember one thing, if markedly prolonged APTT, low fibrinogen, or you are seeing severe thrombocytopenia, suggestive some another condition is present and additional evaluation may be indicated. So platelet count in COVID, mostly normal or maybe slightly increased. It may be slightly decreased also, say around 80,000, 90,000 range. But if it is too low, say 15,000, 20,000, think something else other than the CAC. We do not routinely perform imaging screen for thrombosis as there is no direct evidence which improves the outcome. So only when you are clinically suspecting that some thrombosis, some clots is happening, then you go for imaging. Otherwise, routine routine screening of the imaging is not required. So abnormal coagulation study, if you get in your patient's report, is only used for the prognostic information and level of care. Do not intervene solely based on the coagulation abnormality. Patient is stable, patient has no risk factors of the thromboembolic manifestations, just reports a little bit here and there, and don't start interfering with the treatment intervention. I'm telling you one thing, there is an approach I'm seeing everywhere. People wants to be too much protocolized in the COVID days. So in thrombosis and bleeding, it is always, you need a personalized medicine. You have to understand the risk factor of the patient from the other aspects as well as COVID, then take a decision at the bedside, take a decision on the patient's daily symptoms, and then you have to act accordingly. Just a simple report of APTT, spectral prolonged, say 39 seconds and jump. Don't do that in your clinical practice. So what are the VT prophylaxis ISTH opinion? They are prophylactic dose of anticoagulation for all inpatients. So patients who are in hospital, so they are all need prophylactic dose of anticoagulation. I will come what is the prophylactic dose and what is therapeutic dose down the line. Intermediate dosing or therapeutic dose anticoagulation for selected critically ill patients. Possible continued thromboprophylaxis following discharge. Dr. Lima very nicely explained, make my life easy. That is, I am using the word possible continued thromboprophylaxis. Possible thromboprophylaxis in selected outpatients. So what I want to emphasize from this slide, please practice personalized medicine. All patients with COVID-19 in ICU require thromboprophylaxis. All hospitalized medical non-ICU patients should be treated with prophylactic LMWH. Perioperative VTE prophylaxis is especially important for patients with COVID-19 hospitalized for a surgical patients or surgical procedure. So who are the surgeon in the group, they get a very clear message from the single line. We'd also used VTE prophylaxis in obstetric patients with COVID-19 who are in hospital prior to or following delivery. So repeatedly what I am harping you, please assess the risk factor of the thrombosis, definitely from the COVID point, but don't ignore the other associated risk factors like obesity, previous history of thrombosis, previous history of coronary artery disease, previous history of AMI, male sex, and other behavioral patterns. So now come to a basic point. What is the dosing in the hospital patient? I am very comfortable in using the LMWH. So low molecular weight heparin. Why? Remember one thing, it is the only anticoagulation in the world which has anti-inflammatory property. Warfarin has no anti-inflammatory property, and none of your DOACs has anti-inflammatory property. So LMWH has both antithrombotic and anti-inflammatory property, and which scores best over the other anticoagulation due to this extra added advantage. So we have two LMWH available in the country. One is the enoxaparin, is your Clexane. So creatinine clearance more than 30 ml per minute. Prophylactic dosing is 40 mg once a day. If your creatinine clearance is 50 to 90 ml per minute, 30 mg once a day. Deltaparin is your Fragmin, which is actually the Pfizer, which is not a wet-based. It is a 5,000 unit once daily. If your creatinine clearance is less than 15 ml per minute or on renal replacement therapy, consider using unfractionated or old conventional heparin. This is your dosing of LMWH as prophylactic schedule. When there is a documented thrombosis, use therapeutic full dose anticoagulation for documented diagnosis of thrombosis. In general, forget about COVID. Whenever we hematologists approach any thrombosis, our first questions to the patient in history, and we try to understand, is it a provoked thrombosis or it is a non-provoked thrombosis. Provoked thrombosis means whether there is an infection, whether there is inflammation, whether there is a trauma, whether there is a pregnancy. So these are the things which present in the background. We call it a provoked thrombosis. So consider COVID-associated thrombosis as a provoked thrombosis. So duration of the treatment as per provoked thrombosis protocol. What is provoked thrombosis protocol? So you have to continue your anticoagulation for 3 to 6 months. Minimum 3 months, maximum 6 months. Remember one thing, I've seen a couple of patients come with a proper thrombosis. One patient I've seen very recently from Dombivli also. So patient is clear cut, there is a thrombus, there is a pulmonary thromboembolism, but patient is getting not therapeutic dose, patient is getting prophylactic dose. So therapeutic dose is very clear. If you are using Clexane or enoxaparin, 1 milligram per kg body weight 2 times a day, maximum you can give 80 milligram 2 times a day. If you are using deltaparin or fragmin, your dose will be 200 unit per kg body weight once a day, and maximum you can give 15,000 unit. Sometimes if there is a very bad limb-threatening DVT or massive pulmonary embolism, you can consider reserved fibrinolytic agents. Very important recommendation from ISTH, if there is a clotting happen in the vascular catheter, please use full dose anticoagulation. Treatment of the bleeding. So bleeding is not a major manifestation in the COVID-19. Approach to bleeding is similar to individual without COVID-19. Antifibrinolytic agents like pause, tranexamic acid, what you use in a practice, generally not to be used in COVID-19 because they can tip you or tip your body towards a more thrombotic state and you can land up with a thrombosis. Supplementation with the fibrinogen is not required unless or until the bleeding is proven due to hypofibrinogenemia. Here, just one point I want to add, you will be very happy to know. Now in India, we have a fibrinogen concentrate available, just marketed 2 weeks back. Intas company has that. What is a fibrinogen concentrate? So probably the use of the cryoprecipitate era actually gone with the hypofibrinogenemic bleeding, where you can use directly fibrinogen concentrate. Role of antiplatelet agent, very close to my heart. Dr. Lima is very nicely explained. So single word he told, it is a understudy. But remember, if your patient is taking antiplatelet due to some other reasons, cardiac reasons or hematological issues, then don't stop antiplatelet, continue antiplatelet. I fully okay with Dr. Lima's view of single antiplatelet and single thrombotic agent is more than enough. Triple drug, more tip the patients towards the bleeding manifestations. So that is not very desirable. It is my very personal opinion, because we talk about so much endothelitis. I personally feel that ecospirin will be a good drug, or antiplatelet drug will be definitely a good drug in prevent the COVID-associated coagulopathy. But yes, we don't have any data now. We have to wait for some more time. So just one case study, I will take 2-3 minutes more, and that I learned much. This girl, 10-year-old girl from Indore, they came into lockdown period, febrile for 7 days, CBC suggestive of the pancytopenia, our bone marrow investigations and detailed workup. It is a B acute lymphoblastic leukemia. We started standard induction chemotherapy for this girl. And induction chemotherapy, just for your knowledge, consists of steroid, daunorubicin, vincristine, and L-asparaginase. And among them, L-asparaginase is very thrombogenic. The girl developed severe neutropenic sepsis on day 14 and managed with antibiotics. Day 21, her fever subsided, count started improving, And around day 23, she developed mild cough and difficulty in walking. Doppler suggestive of extensive DVT involving right femoral external iliac and the popliteal vein. Simultaneously, we send a COVID-19, which has actually come back as a positive. So again, it is a provoked thrombosis, but I don't know, it's a COVID associated, or my drug elasparaginase causes this problem, infection itself associated, or just a combination. Very difficult to answer this puzzle, but it's a provoked thrombosis. We continued 3 months of full dose of LMWH, and chemotherapy also restarted after a gap of 2 weeks. And she is now in complete remission from the leukemia point of view, from DVT point of view, not on any anticoagulation at this stage, and continuing her last leg of chemotherapy. Thank you.
Thank you, sir. Thank you very much for a very lucid presentation on COVID-associated coagulopathy from the very basics, its diagnosis. And the therapeutics, sir. We have a few questions for you, sir, if you would be very kind. There are a small subset of patients who present with thrombocytopenia, that is a low platelet count. How do we explain that, sir, in a COVID setup, in a COVID patient?
Yeah, can you hear me?
Yes, sir. Yes, I can.
Yeah. So I told you, mostly we get normal platelet count or increased platelet count. But when you get a lower platelet count, so you have to go your old philosophy. Mild thrombocytopenia, moderate thrombocytopenia, and severe thrombocytopenia. So 50,000 to 1 lakh we call mild, 20 to 50,000 we call moderate, less than 20 is the mild thrombocytopenia. Sorry, severe thrombocytopenia. So mild thrombocytopenia, 70,000, 80,000 you can get. These are mostly immune-mediated thrombocytopenia, which is in your language or our language is ITP-like phenomenon, which does not require treatment. It will spontaneously reversed. I have seen a couple of patients around 15, 20, and mostly they recover without any hiccups. But remember one point. If your platelet count go drastically low, I have not covered that entity. Suppose say 20,000, 15,000, I used only one line. Then something else. And what else? That is called macrophage activation syndrome. So macrophage activation syndrome or hemophagocytic syndrome is an extremely deadly disease. Macrophage activation syndrome can be produced by any infections, any viruses, including the COVID infections. We lost one of our very close colleagues, uncle, very recently from the macrophage activation syndrome. It is a bad disease. You have to very aggressive. You have to, I used the one slide, if you remember, if the thrombocytopenia is significant, your fibrinogen level goes down, your ferritin level goes very high, your triglyceride level goes very high, you think about macrophage activation syndrome and start treating macrophage activation syndrome very aggressively. Otherwise, chance of death from macrophage activation in any circumstances is 50 to 60%. But mostly, it's a benign problem, low thrombocytopenia, you just get away from this.
So we have patients who are discharged post-COVID and they come back with elevated D-dimer levels. Discharged patients, how do we manage them, sir, their D-dimer?
If you remember my second slides, I wasted around 2 to 3 minutes on the D-dimer. So my takeaway is very simple. Don't chase the D-dimer. I have seen one patient, they are actually doing D-dimer daily. Please don't do D-dimer daily. So when you are discharged the patient, there are 2 scenarios or 3 scenarios. Documented thrombosis. So documented thrombosis, provoked thrombosis, you treat for minimum 3 to 6 months. After 3 months, you decide you want to do D-dimer or not. Full dose anticoagulation. You are very concerned that patient may develop thrombosis. You probably give just a, prophylactic dose of any antithrombotic agents, whatever you are comfortable. I am very comfortable with rivaroxaban because I am grown up with that. So if you are doing that, just you probably can do D-dimer say after 2 to 3 weeks or 4 weeks down the line, just to see it is coming down or going up. But don't try to follow aggressively And don't do the dengue-like situation of the platelet count, what you did in the dengue time. So don't put D-dimer, the patient said, that every day patient is going to lab and chasing the D-dimer. So don't chase the value, don't chase the VA, just to have a nap that how is the patient is doing. But I, honestly speaking, don't in favor of chasing the value. And you see in your practice, while you are seeing probably some D-dimers are more than 2-3 months, it's still high.
Yes, absolutely.
My question to you, any other inflammation, do you chase D-dimer? Your answer will be no. So why you want to single out in COVID?
Absolutely. Absolutely, sir. Sir, we have a question from one of the viewers. Post-discharge, when do we give anticoagulants and when do we give antiplatelets?
Yeah, it's a very good question. That question always haunts me. Honestly, I don't know the answer. But I tell you like this way. First of all, individualize the risk factor of the thrombosis of the patient. Starting from age, obesity, prior history of thrombosis, coronary artery disease, prior history of AMI. So in this case, if the patient is young, no bleeding risk factor, you are really not very sure. See, many times in practice, I'm very honest to you, we are sure that patient will nothing happen, but I want to give something so that down the line kuch na ho jaye. So they are I am telling very honestly, because where we don't have any data, that patient after 2 weeks should not blame the doctor, you have not given me and I'm landed up this problem. So here antiplatelet 75 milligram of icosapent, I'm fully okay. But if you feel that patient can develop thrombosis from your risk assessment, so I'm using the word personalized medicine. Absolutely. Here I think rivaroxaban 20 milligram once a day for 4 weeks to 6 weeks. That is, we are also practicing in our hospital institution. We don't have any data for that. It's not a bad option.
Please unmute others. Please unmute. Please unmute others. Please mute this video. Yes, sir.
Yeah.
Yes, sir. Please.
The next question, yeah.
Sir, if we have a patient of hypoxia with a raised D-dimer level and they develop bleeding with low molecular weight heparin, what do we do that time?
So you have to assess the bleeding.
Yes.
Yeah. So you have to assess. So you have to assess the bleeding. Little bit, 1 or 2 spots here and there. Little bit nose bleeding, 1 or 2 drop. So minor bleeding or minor grade 1A bleeding, you just ignore. I don't want to give much importance to this type of bleeding. Or you can skip 1 dose of the LMWH and you can assess the patient. You can reintroduce the LMWH. Or if you are very sure that patient is a thrombosis, you know the patient body is already tipped towards thrombosis. Little bit grade 1 bleeding. I am not very bothered at all. Okay. Because my greatest enemy is the thrombosis. My enemy, bleeding is not my enemy.
Not the enemy, right.
So bleeding you can always manage with little bit transfusion here and there. But thrombosis you have to play very carefully. Otherwise you can lose the patient.
Right. So suppose we have a patient with mildly elevated D-dimer and clotting in the vein flow is seen. Should the full dose of anticoagulation be given to such a patient?
Clotting in the vein flow I'm not using. I use the word very categorically. It is a catheter related problem.
Okay.
So central venous catheter, this is the problem. So vein flow is not qualified for this.
Okay. So we have one last question for you. A pregnant COVID patient, should there be any difference in management of DIC if that settles in a pregnant COVID patient? Because pregnancy itself is a hypercoagulable state. So the management of DIC in a pregnant COVID patient, sir?
So there are 2 things. Number 1, whenever you see this sort of clinical picture, the pregnancy and the query DIC or query CAC, coronavirus associated coagulopathy. So you have to first differentiate between the 2. If it is DIC, just manage like DIC.
So final question, we would like to know, sir, the provoked thrombosis protocol, if you could just explain.
Provoked thrombosis means there are some provoked, so it is nothing with the COVID. Right. So if you read any thrombosis literature, in our DM training program, whenever we taught thrombosis, first thing told us to ask patient whether there is any history of the provocation of the thrombosis is there or not. So any trauma, any fracture, any injury, any infection, any inflammation. So these are pregnancy. So these are we call provoked thrombosis or unprovoked thrombosis. So provoked thrombosis, we know there is nothing written on your thrombosis that I provoked you, but you can assume from the clinical history that it is the provoked thrombosis. And generally the provoked thrombosis, the workup for thrombophilia is not very detailed we do, number one. And number two, our anticoagulation schedule is less compared to the unprovoked. So we recommend from the 3 months to 6 months. So most of the time, suppose the fracture patient come with a thrombosis, DVT, we're probably okay with giving the 3 months of anticoagulation. See, thrombosis, remember one thing, I just lost what I want to add about thrombosis.
Yes, sir.
Thrombosis is like a fever. So fever means what? It can be dengue, it can be malaria, it can be leukemia, it can be autoimmune. So thrombosis itself is a subject in hematology nowadays. So don't treat all thrombus together. So thrombosis is a tip of the iceberg. And what is the behind in the thrombosis? That is the hematologist's greatest interest. And we are always enjoy to unfold the history to the patient and the management accordingly. So this is the ideal platform for the personalized medicine to be practiced.
Absolutely, sir. Thank you so much, sir, for this lucid presentation of COVID-associated coagulopathy and your take-home message of treating the patient with personalized medicine and not treating only the coagulation report. Any other points, any message would you like to give us to the viewers, sir?
And don't chase the report.
Yes, and don't chase the report.
Treat the patient.
Treat the patient. Thank you so much, sir. Thank you very much for being with us here on this platform of IMAFEST from IMA Dombivli. I hand over to Dr. Ashwini Acharya. Dr. Ashwini.
It was a great academic feast indeed. Thank you, sir, for such a wonderful session. Thanks, Dr. Meena, for moderating the session. Sir, we would like to felicitate you. Please accept our e-memento.
Thank you.
Thank you, sir. Thank you so much, sir, for being with us at IMAFEST 2020.
Aditya, please share the e-memento. Because of some technical glitch, we are moving on. Dr. Meena, thanks for moderating the session.
Thank you, Doctor.
We would like to felicitate you and please accept our e-memento.
Thank you, Dr. Ashwini.
Thanks for Fortis Mulin for associating with us educational partners. We are taking a break now for lunch. We will start the afternoon session sharp at 2 o'clock. So please join us at 2 o'clock. Thank you, everyone.